Chalo bachcho, shall we start? Hopefully I'm audible and the screen is visible properly. Okay, great. Now let's talk about sutures, bachcho. Definitely everything comes around it, okay, in surgery. So if I talk about classification of the sutures, first of all. So the basic thing about sutures that you have to remember, ki a lot of times in the internship when you'll go na, they'll be asking you, ki 30 lao, 10 lao, 20 lao, what are these actually? So these are the numbers of your suture. And how they are like different. So please remember they are different from the thickness of the suture. Yes. So you have to remember definitely that the thickness of the suture, okay, is inversely proportional to its number. What do I mean by this? The number is inversely proportional to the thickness. If I see this, what do I mean by this? As the number of the suture increases, the thickness of the suture is going to decrease. Yes, as the number of the suture is going to increase from 1 to 2, okay, from 10 to 20 to 30, definitely the thickness of the suture is going to decrease. That means it will become more thinner and thinner and thinner. That means you have to remember that the suture which is there, which is a number 1 suture, it is the thickest suture. Yes, the number 1 suture which is there, it is the thickest suture. Then we have 10, 20. Likewise, we have sutures till 10, 0 and 11, 0. Okay? So you have to remember that these 10, 0 and 11, 0 wala sutures, they will be our thinnest sutures. Okay? These 10, 0 and 11, 0 wala sutures which will be there, bache, these will be our thinnest sutures. Okay? These will be the finest sutures or the thinnest sutures. They are generally used for which kind of surgeries? They are generally used for the ophtha surgeries. Yes. So these 10, 0, 11, 0 sutures are there now. These fine or these thick, thin sutures are used for ophthalmological surgeries. No issues with this, anybody? That is important. Now, if I talk about this thickness of the suture, as the thickness of the suture decreases, the number of the suture is going to increase. Okay. So as you can see, as the thickness of the suture is decreasing, definitely the number of the suture is increasing. Okay, so that is what is important. Now if I talk about the basic classification of the suture based on the threads, okay, it is made up of how many threads? So based on the number of threads, we can divide the suture as monofilament suture or polyfilament suture. These polyfilament suture can also be called as braided sutures as well. Okay, so monofilament suture, that means the suture is made up of only a single thread. Okay, monofilament suture, that means the suture is made up of only a single thread. That has to be remembered. Whereas braided suture or a polyfilament suture, that means the suture which is there, it is made up of multiple threads which are intertwined with each other. Okay, it is made up of multiple threads which are intertwined with each other, definitely. For example, this is what is a monofilament suture. Okay, what will be a braided suture on the other hand? This will be a braided suture. Okay, this is going to be a braided suture. Can you see this kind of braiding which is there? Okay, this kind of many filaments coming together and intertwining with each other, this is kind of a braided suture. Now can you see definitely if it is a braided suture, bacho, and if I tie a knot with a braided suture, if I tie a knot with this braided suture, definitely is it going to come out easily? No, it is not going to come out easily. Okay, so definitely you have to remember that the braided suture which is there, it is a more stable kind of a suture. यहाँ पे जो तुम knot लगाते हो, the knot that you are going to place with a braided or a polyfilament suture is going to be a more stable kind of a knot, more secure kind of a knot. But on the other hand, definitely if I use a monofilament suture, okay, monofilament जो suture होता है बच्चे, यहाँ पे जो knot मारूंगा मैं, यहाँ पे the knot which I place, definitely it can come off easily. Okay, here definitely it can come off easily. Okay, so that is the first thing. Second problem with a monofilament suture is what? The second problem is it has a strong retention memory. Okay, that means agar for example this is the shape of a suture. Okay, suture is kept like this. So definitely even if I try to pull it out like this, and even if I try to take a suture and tie a knot, it is going to go into its original shape again. That is called as retention of shape. It is going to go again into its original shape. That is called as retention of shape. Okay, so that is important. You have to remember that the monofilament suture which is there, it is made up of single thread and it can slip back easily because it has a strong retention memory. Because it has a strong retention memory, वो अपने वापस original shape में चला जाता है. That's the reason. ठीक है. Whereas on the other hand, as I've told you, this braided or the polyfilament suture, it is made up of multiple threads which are intertwined together. They are easier to handle, as I've told you. Okay, because you can easily tie a knot with them, and these knots are more stable kind of knots. Okay, they will not come off easily because there is a not such a strong retention memory which is seen with the monofilament suture. Second, there will be higher chances of infection. Why? So as we talk about, okay, as we definitely talk about bache, a polyfilament or a braided suture, then definitely you have to remember that these sutures which are there, definitely they will be intertwined with each other, right? And as you can see, if they are intertwined with each other, there will be some space between these sutures. And via these spaces, can infection spread easily? Yes. Via these spaces, definitely the infection can easily spread. Okay, so therefore, higher chances of infection are seen with a polyfilament or a braided suture because of these crevices, these spaces which are left in between. Okay, so that's the important thing. Examples for a braided and a monofilament suture that you have to remember. Monofilament suture ke examples can be remembered as a monocryl, it can be nylon, or it can be catgut. Okay, so monocryl, nylon, or catgut are the best examples of a monofilament suture. But the polyfilament suture, the most commonly used ones. Okay, इसको most commonly use ही क्यों करते हैं? Because ये आसान होते हैं हैंडल करने के लिए. Okay, so the most commonly used sutures, that is your silk and vicryl. अगर स्किन पे करना है तो silk. If you want to do it on the internal organs, then vicryl. These are the most commonly used sutures because they are very easy to handle. ठीक है, so silk and vicryl definitely are the braided or the polyfilament sutures. Now if I talk about another classification of your sutures बच्चे, where they are classified as natural suture or the synthetic suture. Natural suture matlab they are derived from a natural source. That means either from some plant or an animal. ठीक है, therefore they are called as natural suture. Second, they can be classified into absorbable or non-absorbable sutures. ठीक है, absorbable or non-absorbable sutures. That means will they get absorbed on their own or they will not get absorbed, we have to remove them. ठीक है, so depending on that they will be classified as absorbable and non-absorbable. So with the same classification, I'm going to classify these sutures. The sutures which are natural in origin and which are absorbable in nature. Okay, which are derived from plants and animals and which can get absorbed. These examples you have to remember, they are catgut and chromic catgut. Cat is an animal, so definitely a suture derived from her will be a natural suture and it gets absorbed also. Okay, so catgut and chromic catgut are examples of natural absorbable sutures. Then if I talk about natural suture but which is not absorbable, that means we have to remove the suture, we have to cut the sutures. Okay, so definitely that suture you have to remember is silk, because we know that silk can be derived from silkworm. Okay, therefore it is derived from a natural source, but it is not absorbable. We have to remove that suture. Next is if I talk about the synthetic sutures. Synthetic sutures may definitely, okay, which are prepared outside in the laboratory. So these synthetic sutures which are there, which are absorbable in nature, they are vicryl, they are monocryl, and they are PDS. PDS is nothing but polydioxanone. Okay, so there are three types of absorbable sutures which are synthetic in origin. First is definitely the vicryl, second is definitely the monocryl, and third is the PDS, that is polydioxanone. Okay, whereas if I talk about the synthetic non-absorbable sutures, that means they are prepared in the laboratory and they are not absorbed. That means we have to remove them, they will not get absorbed on their own. First is definitely proline and second is nylon. Okay, first is definitely proline and second is nylon. So proline and nylon are synthetic sutures and which are non-absorbable in nature. Okay, so let's write down important points about the types of sutures first, and then definitely I'll come back to the suturing technique. If I talk about the first suture out here, what is the suture? This first suture, image based question has come earlier in the examination also. This yellow color suture which is seen bache, this is what is known as the catgut suture. Okay, this is what is known as the catgut suture. You have to remember this catgut suture which is there. Okay, it is derived from, definitely by name it seems now it is derived from the gut of a cat. Gut is nothing but the GIT. Okay, but it is not derived from the cat's gut. It is derived from an animal's gut, but it is not cat, it is sheep's gut. Okay, so please remember, yes, therefore they play over here. So you have to remember that the catgut suture which is there, it is derived from the sheep gut submucosa. Why only submucosa? Because submucosa is considered as the strongest layer of the GIT. Submucosa is considered as the strongest layer of GIT, not only in animals but in humans also, us also. This has been a previous year question. Strongest layer of GIT is submucosa. So you have to remember it is derived from the sheep gut submucosa. Okay, it is derived from the submucosa of the sheep gut. No issues with this, anybody? That's important. Now, as it is derived from the sheep gut submucosa, definitely it is a natural suture. Yes, it is a natural suture. Is it absorbable or non-absorbable? We know it is absorbable. And as it is a natural suture, bache, definitely it will be absorbed by which process? It is going to be absorbed by enzymatic digestion. Yes. So please remember, the enzymes are going to digest this suture, and by that process it is going to get absorbed. It is an absorbable suture. It will be digested with the help of enzymatic digestion. No issues with this, anybody? Important is, what is the time of absorption? In how much time does it get absorbed? So you have to remember, it gets absorbed within a span of 60 days. Usually it gets absorbed. Okay, it gets absorbed within a span of 60 days. Okay, it gets absorbed within span of 60 days. That has to be remembered. Okay, no issues with this, anybody? And if we talk about a chromic catgut is nothing but usually this catgut having one more layer over it. Okay, so that chromic catgut is there definitely, that usually gets absorbed within a span of 60 to 90 days. Okay, this usually gets absorbed within a span of 60 days. Okay, this is also important. Next important, this catgut now, normally when you open a packet, you will not find any kind of fluid as such, but if you open a catgut suture, you will find some fluid which is present inside it. Why? Because that fluid is used as a preservative to store this catgut suture. What is that preservative used? And this has been a previous. What is the preservative to store catgut suture? So you have the preservative which is used to store the suture is known as isopropyl alcohol. That suture, that preservative is known as, so the chemical isopropyl alcohol definitely is used to break. Hopefully now it's fine, bacho. Hopefully now the voice is fine. See, most of the sutures which is there, they are not going to have any kind of liquid inside it as a preservative. But important is, definitely this catgut suture which is there, it is going to have this liquid known as isopropyl alcohol. And this isopropyl alcohol which is there, it is used to store the catgut suture as a preservative, so that it can be stored for a longer duration of time. Otherwise ये खराब हो जाता है, ठीक है? So that is the basic reason. This is all about your catgut suture that you have to be aware of. Got it? The next one which is there, bacho, these three which I've highlighted, they are the questions. Okay, and in NEET PG definitely enzymatic digestion was also a question. Next one, this is which is suture. This is the with suture. So इतना याद रखना है, violet color vicryl, easy है ये याद रखना, ठीक है? So important is, you can remember this violet color suture which is there, बच्चे. This is nothing but the vicryl suture, and we have to remember that vicryl suture which is there, it is also known as polygalactin. This vicryl suture which is there है ना, it is also known as polygalactin. ठीक है, polygalactin भी बोला जाता है vicryl suture को. It is a most commonly used suture. Important is, this vicryl suture which is there, is it synthetic or natural? Definitely it is synthetic in nature. Okay, it is synthetic in nature. Is it absorbable or non-absorbable? We know it is an absorbable suture. Okay, it is an absorbable suture. Definitely. So if it is absorbable, it should get absorbed within a span. And what is the time span in which it gets absorbed? So you have to remember, it is absorbed within a span of 60 to 90 days. It is usually absorbed within 60 to 90 days. Okay, it is absorbed within 60 to 90 days. And as it is a synthetic suture, bacho, as it is a synthetic suture, it undergoes absorption, but not by enzymatic digestion. अब ये enzyme से नहीं टूटेगा. So then it undergoes digestion, or it undergoes absorption by hydrolysis. Okay, it undergoes absorption or it undergoes the breakdown by the process of hydrolysis usually, because it is a synthetic suture. All synthetic sutures will break down by hydrolysis. All natural sutures will break down usually by enzymatic digestion. Okay? Now important question is, where do we use this vicryl or the polygalactin suture? So this vicryl violet color polygalactin suture, bache, it is commonly used, as I told you. It is mainly used for, this has been a previous year question. It is mainly used for bowel and bladder repair. Okay, this has been used for bowel and bladder repair. जब तुम्हें bowel या bladder ठीक करने होते हैं, for bowel and bladder repair, definitely we are going to use this vicryl suture. We are going to use this vicryl suture. No issues with this, anybody? That is the important thing that you have to be aware of. Okay? The next third kind of suture which is seen, bacho, the next third suture which is seen, definitely, it is this suture which is over here. It is this suture which is over here. ये तीसरा suture कौन सा? Definitely this third suture which is sky blue in color. This third suture which is there, which is sky blue in color, it is called as the proline suture. This is what is your proline suture. We can also call it as polypropylene suture. Okay, so proline or polypropylene is one and the same thing. So please remember, this is a proline or a polypropylene suture, definitely. And normally, you know, there is another thing that is made up of proline. That is a mesh that we use usually during the hernia surgery. जो hernia surgery के बाद जाली डालते हो ना, वो जाली जो mesh होती है, that is also made up of proline. But if you compare both of them, that hernia surgery wala mesh which is there na, it usually looks whitish in color, right? But this is looking sky blue in color. Reason is because this proline suture which is there, bacho, it is covered with a layer. Okay, so please remember this proline suture which is there, it is covered with a layer, okay, to make it somewhat easier to handle, okay, and to give it strength also. तो इस एक्स्ट्रा लेयर की वजह से क्या हो जाता है, द प्रोलीन सूचर becomes more stronger and definitely it becomes somewhat easier to handle as well. ठीक है, so this proline or the polypropylene suture is sky blue in color. Important is it is definitely a synthetic suture. Polypropylene से ही पता चल गया है ना, so it is definitely a synthetic suture. And next important thing, it is non-absorbable suture. Yes, it is not absorbed. It is a non-absorbable suture. ठीक है, synthetic non-absorbable suture it is. Where do we use it? This has been a question. Where do we use it? Important is you have to remember it is generally used to fix the proline mesh during hernia surgery. During hernioplasty, definitely, whenever we want to fix that proline mesh, that is fixed with the help of a proline suture itself. Okay, so I'll not write that. The next two important things are definitely it is used for vascular repair. Yes, if you want to repair a major artery, like for example, an aorta or an inferior vena cava, for such vascular repairs, the suture that we generally use is this proline suture itself. Okay? Whereas the second important thing that you have to remember, it is also used for the rectus sheath repair, and both of these have been questions. Okay, vascular repair and another time it was rectus sheath repair. So दोनों time के लिए you have to answer it as proline sutures itself. Okay, rectus sheath is what? Definitely, I hope all of you are quite aware, the anterior abdominal wall in the center is formed by rectus abdominis muscle. Okay, जो 8 packs तुम्हारे बनाती, 6 packs, 8 packs जो भी हो. Okay, so definitely that muscle is usually covered with the help of a sheath or a fascia. So if you want to repair that rectus sheath, it is done with the help of proline suture itself. Okay? So please remember, proline suture which is there, it is used for vascular repair or it is used for rectus sheath repair. Okay, it is used for vascular repair or it is used for rectus sheath repair. Both of these are important questions. Okay? No issues with this, anybody? So that's important. Okay? The next suture which is in line, the next suture, the fourth suture that we are going to talk about, bache, is this one. And what is this? Definitely the black color suture that you can see, and it is not made up of a single thread, but it is made up of multiple threads. That is a polyfilament or a braided suture it is. This black color suture is nothing but the most commonly used suture, that is a silk suture. Yes, this is nothing but a silk suture definitely. And this silk suture which is there, you have to remember it is black in color. Yes, important is a braided suture. What do I mean by a braided suture? That is polyfilament suture. Therefore, the knot which is there, it will not easily come off and it is much easier to handle. Therefore, we are commonly using it. Okay, so it is a braided suture. We know it is a natural suture because naam mein silk hai uske. It is a natural suture and it is a non-absorbable suture. Yes, we have to remove it. It will not get absorbed on its own. It is a non-absorbable suture. It is a non-absorbable suture. No issues with this, anybody? That's the important thing you have to remember. कोई दिक्कत नहीं है इसमें. Important is, please remember, braided, natural and non-absorbable suture. It is derived from what? As I've told you, it is derived from silkworm itself. It is derived from silkworm. That is the reason why it is considered as a natural suture. It is derived from the silkworm itself. Important. What is the use of the suture? Where do we use it? So as I've told you, it is a very common suture. That means it is used for skin suturing. Yes, for all your skin suturing, definitely you are going to use the suture that is known as the silk suture. Okay, so for your skin suturing, definitely the best suture which is there, bache, it is known as the silk suture. And second important, it is also used to fix the drains. It is also used to fix the drains. For example, if you want to fix a drain particularly after a surgery, okay, you want to fix a drain. To fix that drain, or even to fix the intercostal drainage tube that you insert in a patient of usually pneumothorax, that also is fixed with the help of the silk suture itself. Okay, so skin suturing and to fix the drains, the best suture that we use is definitely the silk suture. Okay, no issues with this, anybody? That is all about your silk suture. And the next suture which is in line is the sixth suture that you have to, the fifth suture that is in line is known as the nylon suture. Yes, this fifth suture which is there, it is a nylon suture. If I talk about the nylon suture now, see, nylon का जो brand name है or the name with which it comes in the market is the Ethlon. So usually a lot of times you will be like, yeah, Ethlon क्या है? So Ethlon is nothing but nylon itself. ठीक है? So nylon or Ethlon suture, you have to remember this nylon suture which is there, बच्चों. This nylon suture which is there, you have to be aware of this, that this nylon suture is definitely a synthetic suture. Nylon है ना? So it is a synthetic suture. And second, it is a non-absorbable suture. Second, it is a non-absorbable suture. Okay, so these are the important points to be remembered. Then the uses of nylon suture are important. It can be used instead of silk. हाँ, जहाँ पे silk available नहीं है, we can easily use the nylon suture. Or whenever we need definitely more strength than the silk. Silk is stronger, but more stronger is nylon. ठीक है, definitely silk से ज़्यादा strong क्या हो सकता है? Nylon. So that is the reason if we need more stronger suture, then we can use nylon. For example. Okay, for example, usually for skin suturing, definitely we can use nylon as well. Yes, Ethlon can be used. Skin suturing के लिए commonly we use silk, but it is not like only silk is used. Nylon or Ethlon can also be used. ठीक है, that's the important one. Second important, it can also be used to fix the drains as well, just like silk. Important. Second, it is used for tendon repair. Yes, as I've told you now, for tendon sheath repair, tendon sheaths are very strong. Okay, so definitely tendon repair or tendon sheath repair. तो जब करना हो तुम्हें, so definitely we need a strong suture, something like a nylon itself. So tendon sheath repair or tendon repair, it is the nylon suture. And last, which has been a previous year question also, it is used for ophtha surgeries. Yes, for ophthalmological surgeries which is there, bacho, we need nylon sutures. For ophthalmological surgeries which is there, we usually use this nylon sutures which are there. But which ones? The 10-0, 11-0. So fine sutures, so fine nylon is generally used for taking the sutures in a ophtha surgery, cataract surgery वगैरह में. Okay, we generally use this nylon suture itself. Okay, but very fine, very thin wala. And last important suture that you have to be aware of is definitely, just remember the name and the use, that is called as a monocryl suture. Monocryl 3-0 which is there, to be specific, monocryl 3-0 which is there, bacho, it is the best suture for subcuticular suturing. Yes, monocryl 3-0 which is there, it is the best suture for subcuticular suturing. What do I mean by subcuticular suturing? So first of all, before closing the skin, we have to close the subcutaneous tissue. And to close the subcutaneous tissue, the best suture that we can use, we commonly use Vicryl, but the best suture that we can use for subcuticular suturing has to be monocryl 3-0. Okay, it has to be monocryl 3-0. This has been a previous year question. Subcuticular suturing के लिए what is the best suture? Answer is monocryl 3-0. ठीक है? No issues with this, anybody? That's important to be remembered. Now, if I talk about the suturing technique once, okay, then if I talk about the suturing technique, shall I? Okay, if I talk about the suturing techniques, just understand it. Images वगैरह commonly नहीं आते हैं. You will be taught in definitely your internship time as well. I'm just giving you an explanation just once. Okay. Important is first, the most common type of sutures that we take are called as a simple interrupted suture. सब कुछ उसके नाम में simple है and interrupted है. Interrupted मतलब they are not continuous. Okay, एक suture लोगे, गांठ मारोगे, दूसरा suture लोगे, गांठ मारोगे. That means you will take one suture, tie a knot, cut it. You will take another suture, tie a knot, cut it. Again, this is what is why they are called as the interrupted sutures. Okay, so these are the simple interrupted sutures, bachcho. Can you see? I have taken a bite from here. Okay, I have gone below the wound. Okay, I have gone below the wound definitely. I've gone from the wound. I've brought the suture out from another bend, and then definitely I've tied a knot. and then definitely I have tied a knot. Okay, this kind of a suture which is there, bacho, this kind of a suture which is there, it is known as the simple interrupted suture. Okay, I have once tied a knot, I have cut it now. ठीक है, सबसे पहले ये देख लो. Okay, so this is a simple interrupted suture. I have taken a bite from here, I have gone over here, I have come back again, and then I have tied a knot, and then I'll cut the suture. Then again I'll take a bite from here, I'll go, I'll come back, I'll tie a knot, I'll again cut. Okay, so definitely at a certain distance, at specific intervals, definitely you are going to actually take these sutures. These are called as simple interrupted sutures. The next one is the simple continuous suture. Now what is a simple continuous suture? That means you are going to take the first bite, and then you're not going to tie a knot. No, you are not going to tie a knot. You will keep on taking another bites. You will keep on taking another bites. Agli bite dete jaoge. You will keep on taking another bites, and then finally you are going to tie a knot. And then ultimately you are going to tie a knot. But the problem is, please remember, if this knot comes out, then अगर यही फाइनल गार्ड जो मारी तुमने, आखिरी जो गार्ड मारी, अगर यही स्लिप हो गई तो पूरा सूचर खुल जाता है. Okay, so please remember, if the final knot comes out, the whole simple continuous, okay, so please remember, the whole continuous suture is going to come off. Okay, so that is the reason you have to remember that this simple continuous suture will have highest chances of slippage. Okay, this is the important one. Please remember, the simple continuous suture will have highest chances of slippage. अगर ये पूछा जाता है कौन से suture में सबसे ज्यादा slip होने के chances होते हैं, answer is the simple continuous suture. Okay, answer is the simple continuous suture, because if one knot comes off, whole suture is going to come off. Okay, that is important. Now next important one is बच्चों, this is the horizontal mattress sutures. The mattress sutures which are there ना, इनके साथ approximation अच्छा होता है. Okay, the skin edges which are there or the tissue edges which are there, they are approximated absolutely properly with the help of a mattress suture. Therefore mattress sutures are superior, mattress sutures are better usually. ठीक है, so if I talk about mattress, there are two types of mattress. One is called as the mattress, it is the horizontal mattress suture. My first suture, like definitely during surgery, was during my internship. Okay, so definitely horizontal mattress sutures or the vertical mattress sutures, if I talk about बच्चों, so definitely see horizontal mattress suture में क्या होता है, or in horizontal mattress suture definitely what are we going to do? Let's see. First we are going to take a bite. Okay, first we are definitely going to take a bite. Okay, we are going to come over here, then we are going to travel a distance, थोड़ा आगे जाएंगे, and then we are going to again take a bite. We are going to go back again on the same side, and then we are going to finally tie a knot. This is what is called as a horizontal mattress suture. Okay, if I have a pen, I can show it to you. Just a minute. Okay, this is called as the horizontal mattress suture definitely. ठीक है, just a minute. Let's see if I can show it to you on this. So important is, याद रख लो horizontal mattress कैसा होता है. For example, this is your tissue. ठीक है, अब ये tissue में क्या हुआ है definitely. Okay, this is definitely the wound which has happened in the tissue. ठीक है, this is the wound which has happened in the tissue. Now we are going to suture it. How we are going to suture it is, see, for example, we are going to go from here. ठीक है, I am going to take a bite from here. ठीक है, and now definitely we are going to come back from here. थोड़ा सा आगे जाके वापस आना है. We are going to come back from here. This type of a suture which is there, it is known as a horizontal mattress suture. This type of a suture which is there is known as a horizontal mattress suture. I've come from here, I've traveled a distance, I've come back from some distance. This is a horizontal mattress suture. Now important is, horizontal के बाद vertical mattress suture. Vertical में क्या करते हो? See, I am going to travel 1 centimeter away from the first bite. I am going to take will be 1 centimeter away from the wound. It will be 1 centimeter away from the wound. Then I am going to come back. 1 millimeter away from the wound. I am going to come back 1 millimeter away from the wound. तो अगर ऐसा kind of suture है, this is a tissue, so I am not able to show properly. Okay, this is what is the vertical mattress suture बच्चों. If I am taking a suture definitely 1 centimeter away and 1 millimeter away from the wound, this is a vertical mattress suture. ठीक है, so that's important. So ठीक है, So horizontal mattress is this one. Vertical में क्या बोल रहा मैंने, vertical में we are going to take the first bite 1 centimeter away from the wound. Okay, then we are going to take the first bite, and then the second bite which is there, I am going to take 1 millimeter away from the wound. थोड़ा और नजदीक आके लेना है wound के, and then I am going to come back, and then I am going to finally tie a knot. Okay, this is what is the vertical mattress suture. This is what is the vertical mattress suture. Okay, so these are the types of mattress suture. And what is this? Definitely these are nothing but subcuticular suturing. This is a running subcuticular suture which we are taking, and this finally is important. This is what is a purse string suture. Why the purse string suture is important? See, purse string suture matlab we are taking one bite, we are taking multiple bites, then okay, we are taking multiple bites after that, we are taking multiple bites after that, definitely, ठीक है, and after that finally जो end आता है, we are going to tie that end, we are going to tie both the ends over here, ठीक है. This is what is called as a purse string suture. This is classically known as the purse string suture. Important is this purse string suture which is there, बच्चे, this purse string suture which is there, you have to be aware of this fact that when you are going to tie the knot, okay, when you are going to tie the knot, definitely, okay, when you are going to tie the knot of the suture which is there, okay, so definitely what is going to happen, you are going to actually close the opening. For example, if there is a circular wound or if there is a circular opening and you want to close that circular opening, take a knot all around the suture, take a suture all around the wound, and then try to pull both the threads. As you try to pull both the threads, what is going to happen? Definitely this cavity is going to close. This cavity which is there, it is going to close. तुमने दादी माँ का बटुआ देखा होगा ना? If you have seen the purse a granny carries, okay, that granny carries, or nowadays only definitely a lot of girls also carry the same. ठीक है? So definitely that has two strings. If you pull those two strings off, the mouth of the purse closes. Therefore, this is called as the purse string suture. This is what is known as the purse string suture. But this purse string suture which is there, it is used to close a cavity. It is used to close a cavity. It is used to close a cavity. And second, to bury the base of appendix. After appendicectomy, the base of the appendix which is left, you have to bury the base. So definitely that base will be buried. Okay, for example, this is the appendix. This is the base of the appendix. Okay? This is the base of the appendix which is left behind. Now you have to bury the base of the appendix. So for that you are going to take a purse string suture all around and you are going to close this. You are going to close this. Okay? So that is what is important to be remembered. Okay, so no issues with this. So these are the important ones. Just remember the purse string suture. It is used to close a cavity, or it is used for burying the base of appendix. Sorry, bury base of appendix. Bury the base of appendix. उसके लिए use होता है. And definitely highest chances of slippage are usually seen with a simple continuous suture. Okay, so let's move further. Now if I talk about the needles, can you see every suture is having a needle attached to it? Yes, the sutures also have needles directly attached to it. Now there are two types of sutures, bachcho. There are two types of sutures usually. One is called as the round body needle, and second is called as the cutting or the reverse cutting needle. Yes, it can be either a cutting or a reverse cutting needle. Okay? So now round body needle mein, if I cut the needle in between, I'm going to get a circular point. So this type of a needle will have a sharp end or a blunt end. थोड़ा सा blunt end होता है. Okay? So round body needle is not too sharp. It is somewhat blunt, and therefore it is used for which structures? Therefore it is used for visceral structures, for the viscera. What do I mean by viscera? Viscera means your bowel, okay, that is your intestine or your internal organs, okay. So if you want to take a suture on the viscera or your delicate organs, definitely you should use a round body needle. You should use a round body needle because it is somewhat blunt, it is not too sharp, it is not going to cut or injure the structures too much. But if I talk about the cutting or a reverse cutting needle, in cutting or a reverse cutting needle, bache, if I cut the needle in between, I am going to get a triangular shape. Can you see? One of the point will be sharp. One of the point of this needle is going to be sharp, definitely. So that is the reason these sharp needles, that is your cutting or the reverse cutting needles, they are generally used for tough structures. Tough structures, something like skin, fascia, tendon, scalp. Okay, so for these tough structures like the skin, fascia, tendon, scalp, you have to use a cutting or a reverse cutting needle. Okay, so please remember, ये बहुत बार होता है. Definitely if you come first time in the hospitals, definitely for your internship, a lot of people are not aware कि round body needle अलग होता है and cutting needles अलग होता है. If you ask the sister कि sister जी एक needle एक suture देना, so definitely you want to take a suture on the scalp, ठीक है, और वो sister कौन सा suture दे देती है, so the sister usually gives you a round body suture, and definitely तुम देखते नहीं हो कि ये round body है, reverse cutting है, definitely, and you try to definitely take sutures with that round body needle. प्रॉब्लम ये हो जाता है कि तुम कितना भी जोर लगा लो, वो राउंड बॉडी घुसेगा ही नहीं स्कैल्प में. Okay, so that round body needle is not going to go inside the scalp because it is blunt, it is not sharp, it is not made for tough structures like the scalp. वो needle break हो जाएगी and needle definitely bend हो जाएगी, but it is not going to insert inside the scalp. ठीक है, you keep on struggling and then तुम अपने पीछे से पूछते हो सर ये जा ही नहीं रहा है, so definitely then he tells you बेटा this is a round body needle, it is not made for the tough structures. ठीक है, so that's the important thing, please remember that. ठीक है. Now if I talk about the knots बच्चे, again knots are not so commonly asked, at least you have to remember कि various kinds of knots होते हैं. This is the simple knot not used for surgery. This is definitely the granny's knot which is there. But what is the problem with granny's knot? This granny's knot which is there, it is a very insecure kind of a knot. Okay, what do I mean by insecure knot? That means high chance of slippage. Okay, this granny's knot which is there, it is a very insecure kind of a knot, that is high chances of slippage. तो कभी अपनी नानी को या दादी को definitely you might have seen them making sweaters ना, okay, making sweaters for you. क्या होता है definitely, if one knot of that sweater comes out, if the final knot of that sweater comes out, you can pull off the complete line. Okay, तुम पूरी की पूरी line खींच लेते हो. Reason is because the knots that the grandmother has taken are usually the granny's knots which are very easily slipped off. तुम एक अगर फाइनल थ्रेड खुल जाती है उसकी ना, पूरी की पूरी लाइन इजीली निकल आती है. दैट इज द रीजन. ओके, दैट इज द रीजन बिकॉज इट हैज हाई चांसेस ऑफ स्लिपेज यूजुअली. ठीक है, हाउ टू आइडेंटिफाई इट इन अ पिक्चर? सो प्लीज रिमेंबर यू हैव टू फॉलो दिस ब्लू थ्रेड नाउ. ओके, सो कैन यू सी द ब्लू थ्रेड व्हिच इज देयर, once it is going beneath the loop, other time it is going above the loop. Okay, so this blue thread which is there, it is once going beneath the loop, other time it is going above the loop. तो एक टाइम वो नीचे से जा रही है, other time it is coming above the loop definitely. So this is what is called as a granny's knot. The second one which is called as the square of the reef knot. The square of the reef knot बच्चे, this is the secure kind of a knot. The square of the reef knot which is there, it is a secure kind of knot. That means it is not going to slip off easily. It is not going to slip off easily. How to identify it in the image? So you have to remember that, follow the blue thread again. Here can you see both the ends of the blue thread? Both the ends of this blue thread are going above the loop or either they are going below the loop. Okay, so you have to remember both the ends which are there, they will go above or below. So if both the ends of a thread either go above the loop or below the loop, that is what is a square or a reef knot, which is a secure kind of a knot. But if one thread goes above, one thread goes below the loop, definitely then you have to remember it is an insecure kind of a knot, which is known as a granny's knot. It is going to slip off very easily. Okay, so that is the basic reason that you have to remember. Okay, so yaad rakh lo, for example, now in this it wouldn't be there. This one which is there bachcho, definitely this is, for example, this is one end, this is your second end. Okay, if granny's knot mein kya hota hai, definitely the first end which is there, the first end which is there na, it remains on the same side. The first end which is there na, it remains on the same side. Can you see both the ends are on the same side? And can you see if I leave this knot, it is going to come off very easily. It is going to come off very easily. But the next time what I'm going to do is tie a square knot. What is a square knot or a reef knot now? Square knot mein definitely crossing will be seen. Now what is going to happen? This thread is going to go on the opposite side. Okay, so this is what is the square knot, the first one. Okay, definitely I'm again going to cross it up. This is what is a square knot. Okay, this is what is a square. Can you see a square has been formed in between? Yes. So this is what is kind of a square knot which is seen, which is a very secure kind of a knot which will not come off easily. And the most secure kind of a knot which is seen, the most secure kind of a knot which is seen, bache, it is the surgeon's knot. Yes, the most secure knot which is there, it is not going to come off easily. The most secure kind of a knot is the surgeon's knot, which is not coming off easily. Why? The reason is, can you see it has two throws? It is having two throws followed by one throw out here. It is actually having three throws. Okay, पहले दो बार तुम ये करते हो, cross करते हो, and then again you cross it one more time. Okay, so definitely, okay, this is a, for example, you are actually taking two square knots first. You are taking two square knots first, and once you have taken these two square knots, definitely, ठीक है, ये दो square knot हो गई. Then after that you will take the third one as well. Okay, you are going to take the third one as well, and this is what is called as the surgeon's knot. Okay, this is what is going to be called as the surgeon's knot. No issues with this, anybody? That is important to be remembered. Okay, so if there are two throws followed by one throw, this is the easiest one to identify. This is what is known as the surgeon's knot. Now, let's see where do we hold the needle with the help of a needle holder. Okay, so please remember, where do we hold the needle with the help of a needle holder? First of all, there are two ends to your needle. The end where the suture is going to be attached, is called as the swaged end. This end where the suture is going to be attached is known as the swaged end. Whereas the point which is there, this is called as the pointed end. This end pe point ho, okay, sharp point, that is called as the pointed end. Where do we hold the needle with the help of a needle holder then? It is 1/3 from the swaged end and 2/3 from the pointed end. It is 1/3 from the swaged end and 2/3 from the pointed end. Can you see? 1/3 from here and 2/3 from here. That is the best side to hold the needle with the help of a needle holder. Reason is, bache, because you can easily manipulate the needle, you can easily turn the needle, okay? And जब तुम needle turn करते हो ना, it should be actually the movement at the level of the wrist, okay? It should be at the level of the wrist, the movement should be there, ठीक है? तो आगे जाके movement नहीं करोगे, it should be at the level of the wrist, ठीक है? So that has to be done. So please remember, this knot which is the needle which is there, it should be held where? This has been a question, okay? This has been a previous year question. So please remember, needle should be held. Needle should be held 1/3 from the swaged end, 1/3 from the swaged end, okay, and 2/3 from the pointed end, and 2/3 from the pointed end. Okay, 1/3 from the swaged end and 2/3 from the pointed end is the best side to hold the needle with the help of a needle holder. No issues with this, anybody? That has to be remembered. That has to be remembered now. Now, if definitely I've told you about some non-absorbable suture, non-absorbable, matlab definitely they're not going to get absorbed. So we have to remove them. So what are the suture removal timings that have been asked in some of the examinations prior? So the suture removal timings at different sides of the body will be different. Okay. सबसे earliest कौन से sutures निकाले जाते हैं? The earliest to be removed are the face sutures. Yes, the earliest to be removed are the face sutures. They are removed as early as 3 to 5 days. Reason is, if suture stays over a site for a longer duration of time, they are going to leave a mark. Yes, if suture stays over a particular site for a longer duration of time, they are going to leave a mark. And that is the reason on face, definitely nobody wants a mark. So definitely the face sutures are going to be removed immediately as soon as the alignment is done, usually after 3 to 5 days. Okay, then we have to remove the scalp and the neck sutures. Scalp and neck sutures are usually removed within a span of 5 to 7 days. Scalp and the neck sutures are usually removed within a span of 5 to 7 days. Then comes the thorax and the perineal sutures. The thorax and the perineal sutures are usually removed within a span of 10 to 12 days. Thorax and the perineal sutures are usually removed within a span of 10 to 12 days. And finally will be your abdominal sutures. Reason is, abdominal wall jo hoti hai, it is very strong. And if you remove the sutures early, what is going to happen? Definitely the strength will not be that much and definitely there will be burst abdomen. Okay, so to avoid that, definitely you remove the abdominal sutures the last, and that is around 12 to 14 days. So 12 to 14 days later you are going to remove the abdominal sutures. Okay, so that is the important thing you have to remember. Face ke sutures are removed usually 3 to 5 days later. Okay, scalp and neck ke sutures usually 5 to 7 days later. Thorax and perineum ke around 10 to 12 days, and abdominal sutures, the last ones, usually more than 12 to 14 days. No issues with this, anybody? Now, sorry. Now the next one, some important instruments. This is an important instrument. What is this? This bache is a circular stapler. This is actually a circular stapler. Now you might be hearing na कि टाके नहीं मारे बस stapler लगाया था. Okay, nowadays a lot of surgeries are usually without sutures. Definitely we just try to apply the staplers usually. This circular stapler which is there, bacho, it is used for which surgeries that you have to be aware of. Okay, this circular stapler which is there, it is used for a surgery which is the surgery of choice for hemorrhoids nowadays. Yes, hemorrhoids ke liye now the conventional open surgery is not the treatment of choice. The surgery of choice nowadays for hemorrhoids is actually a stapler hemorrhoidopexy. Okay, because there's complications associated with it. So definitely stapler hemorrhoidopexy. Okay, stapler hemorrhoidopexy is a common surgery for which we are going to use this circular stapler. And the second surgery which is there that you have to remember is the LAR. The second surgery which is there, it is known as the LAR. What is LAR? Definitely low anterior resection. It is low anterior resection. Low anterior resection ka matlab when we are going to remove the rectum and the sigmoid colon of the patient. Okay. When we are going to do rectosigmoidectomy, and then definitely we are going to do a anastomosis. Okay, so one surgery mein low anterior resection that will study in colorectal cancer. For that also we are going to use this circular stapler itself. Okay, we are going to use this circular stapler itself. No issues with this, anybody? This is the best one. Next one, bachcho, which is there, this one which is there, this is a disposable stapler. And what is the use of this disposable stapler? You have to remember that this disposable stapler which is there, it is used to fix a skin graft. It is used to fix a skin graft. Okay, so the skin grafts which are there, definitely they are usually fixed with the help of this disposable stapler. Definitely I'll show you at the end of the class, definitely. Okay, the images in that I'll tell you about the skin grafts of my patients. Definitely in that you can see definitely it is easily fixed. Okay, so at the end we'll see the pictures. So disposable stapler, it is used to fix the skin graft. Next important one is this, and this was a previous year question of June 2022 FMG examination. So please be aware of this kind of a stapler which can be asked again in your exam. This is what is a linear stapler, bachcho. This is what is a linear stapler, and this linear stapler which is there, definitely this linear stapler, you have to remember, it is generally used for gastrointestinal surgeries. Yes, it is generally used for your gastrointestinal surgery. For GI surgeries, like for a case of Zenker's diverticulum. Okay, in Zenker's diverticulum we are going to study about a Dohleman's procedure. What is that Dohleman's procedure? Where we make the Zenker's diverticulum a part of the esophagus. That is called as diverticuloesophagostomy. In that surgery also we are going to use the same stapler known as the linear stapler itself for GI surgeries mainly. Okay, or you can even use it for, so definitely one is the, you can just write on, it is diverticuloesophagostomy. Okay, it is diverticuloesophagostomy. That is one of the surgeries. And the second one that you have to remember, it is definitely sleeve gastrectomy. Okay, that is a bariatric surgery that we are going to study. It is known as the sleeve gastrectomy. What is the sleeve gastrectomy? I'll talk about that later. Definitely, we are going to reduce the size of the stomach. That is what is sleeve gastrectomy. Okay, so that is important. So for these two surgeries, definitely we commonly use this linear stapler. Okay. Now the disposable stapler, matlab it is one time use and throw. Okay, yes, once you are done with the stapler, you have to throw off the stapler. Okay, so that's the important thing. Now if I talk about the three drains which are there, which are important and has been asked in the examination sometime or the other time. The first drain which is there. Now first of all, why do we need drains? Why do we need drains? That's the most important question. Important. For example, now you have performed a breast surgery in a patient. Okay, patient was diagnosed with a case of breast cancer, and she was operated. She underwent a MRM. What is MRM? Modified radical mastectomy. Okay, you removed her breast, and definitely as lymph nodes were also involved, you also did an axillary lymph node dissection. You also removed her axillary lymph nodes. Now after this surgery, what is the most common complication? After this surgery, the most common complication is there is collection of fluid over here. There is actually collection of serous fluid over here in the axilla, and that is called as a seroma. Okay, seroma is nothing but definitely collection of serous fluid over there. So definitely you have closed it and you have not left any drain after the surgery. Ab kya ho jayega? Now when the patient will have the seroma, definitely you have to cut it open and you have to again operate the patient for the drainage of that seroma. Was it even required? No. Okay, how it would have been prevented? It would have been prevented by just after the surgery if you would have left some drain over there. अगर तुम कोई ड्रेन डाल देते वहां पे at the surgery site, definitely for few days you should have kept the drain over there. If there was no output from the drain, definitely you should have removed the drain. Okay, so that is how definitely these can be prevented. Okay, these can definitely be prevented. No issues with this, anybody? That's the important thing. So please remember this one which is there, bacho. This one which is there, it is known as the Romovac suction drain. This one which is there, it is known as the Romovac suction drain. Okay, this one is known as the Romovac suction drain. If I talk about the Romovac suction drain, bacho, this is a negative pressure drain. Why do I call it as a negative pressure drain? Okay, the reason is, please remember, when you are fixing this drain, you are going to press this drain. Okay, when you are going to fix this drain, you are going to press this drain and then you are going to release it. When you release this drain, definitely there is a lot of negative pressure inside the drain. there is a lot of negative pressure inside the drain, and due to that negative pressure there is a suction which is created, right? There is a suction which is created. Due to that suction or due to that vacuum, any fluid which is there, which is collected at the surgical site, any blood, any fluid which is collected at the surgical site, that will be sucked in the drain, that will be pulled in the drain. We can even do charging of this drain. What do I mean by this charging? Electrical charging nahi. What we can do is, we have to clamp this drain. यहाँ पे देख रहे हो ना, इसके साथ बंद कर देना उसको. We have to clamp this drain. Then we have to again press it, and somebody else is going to fix it. तो अगेन तुमने चार्ज कर दिया उसको, अगेन तुमने और नेगेटिव प्रेशर भर दिया उसमें. डेफिनेटली एज मोर नेगेटिव प्रेशर इज जनरेटेड ओवर हियर, मोर वैक्यूम, मोर सक्शन, एंड इफ देयर इज एनी fluid which is collected at the surgical site, definitely that will be sucked into this drain. So definitely please remember this Romovac suction drain बच्चों, it works on the principle of negative pressure. It works on the principle of negative pressure. It is a negative pressure drain. Okay, it is a negative pressure drain, definitely, that you have to remember. ठीक है? And when do we remove this drain बच्चों? So this which is there now, this is attached to the drain itself पहले से. This is actually to insert the drain. Okay, this is to actually take the first bite. Okay, so you usually take this bite. Once you are inside the site, definitely यहाँ से cut कर देते हो. Then you are going to cut it off. Okay, this needle is only there. This needle or this rod which is there, it is only there to insert the drain once. ठीक है? एक बार drain को insert कर दिया, definitely this is going to be discarded. ये फेंक दोगे फिर उसके बाद. Got it? So that is important. Now when are you going to remove the drain? So please remember, we usually remove the drain when the output of the drain is less than 40 cc per day. When the output of the drain is less than 40 cc. Okay, so when the output of the drain is less than 40 ml or 40 cc, definitely, okay, that is the time we are going to remove the Romovac suction drain. Okay, this has been a previous year NEET PG question, so be aware of that fact. ठीक है? इसी का miniature version भी आता है, that is called as a minivac suction drain. There is also a miniature version of this Romovac suction drain which is known as a minivac suction drain. ठीक है? The next one is this one बच्चों, this is also drain. Romovac suction drain, as I've told you, कौन सी surgeries के बाद use होता है? It is actually used after the MRM surgery. That is nothing but a modified radical mastectomy. That is your breast surgery, and it can be used after thyroid surgery also. Yes, it is even left over there after a thyroid surgery, because in these surgeries, even after surgery, there is high chance of fluid collection or high chance of hematoma formation. To avoid that or to prevent that, definitely we are going to insert the drain after these two surgeries, MRM and thyroid surgery. Got it? Next one which is there, bache, it is this one. What is this? This is actually the similar kind of a drain, definitely, but this has a different name. It is called as a Jackson-Pratt drain. This is which is there, it is known as the Jackson-Pratt drain. Okay, this one which is there, it is known as the Jackson-Pratt drain. It is the same kind of a drain, negative pressure drain, but a smaller or a miniature version known as the Jackson-Pratt drain. Okay? Next important is this. What is this? And ये Jackson-Pratt drain जो है ना, it is left usually after, with surgery, it is usually left after a sentinel lymph node biopsy. I'll talk about what is sentinel lymph node biopsy, don't worry about that. ठीक है? Sentinel lymph node biopsy is what? For example, there was a cancer in a patient, ठीक है? And definitely the lymph nodes of this patient was not palpable. So if the lymph nodes are not palpable, we are not going to remove that lymph nodes. But are we sure that if lymph nodes are not palpable, that means they are not involved? No, we are not sure, right? So for that reason, we are going to do a sentinel lymph node biopsy. What do I mean by sentinel lymph node biopsy? We are actually going to inject a dye, or we are going to inject a contrast around the cancer site. From the cancer, definitely, it is going to go till the lymph nodes. Why? What are sentinel lymph nodes? Sentinel lymph nodes are definitely the first draining lymph nodes of a cancer. Cancer सबसे पहले किस lymph node में drain करता है? उन lymph nodes को बोला जाता है sentinel lymph node. Okay, and if you want to take a biopsy from that lymph node, you have to first inject a dye at the cancer site. Then that dye is going to go till the lymph node. That lymph node will be highlighted, and then definitely you are going to take the biopsy from that. That is what is called as a sentinel lymph node biopsy. Okay? For after that, definitely you can leave a Jackson-Pratt drain over there. Next, the last one which is there, bache, it is known as the abdominal drain. This abdominal drain which is there, this abdominal drain, definitely it is left after abdominal surgeries. Okay, it is left after abdominal surgeries. And where do we leave it? We leave this abdominal drain which is there in the pelvis of the patient. After abdominal surgeries, we leave this abdominal drain and it is left in the pelvis of the patient. Why? Because just due to gravity, pelvis नीचे होती है ना, definitely. So just due to gravity, if there is any collection in the abdomen, it is going to drain inside the pelvis itself. Therefore, we have to keep this drain inside the pelvis itself. Okay, so this end of the drain is kept inside the pelvis, and this bag keeps hanging out. If we see there is less than 40 cc of output, then definitely we are going to remove the drain. Just a minute. वीडियो और वॉइस दोनों ब्लर हो रहा है. बाकियों के लिए भी हो रहा है. हम लोग हो गया. Now clear? Now is it clear, बच्चों? Please let me know. Okay, great. Chalo. Drainage is nothing. Drainage is just the last one is the abdominal drain, which is placed usually after an abdominal surgery. Okay, and definitely this end of the drain which is there, we have to keep it inside the pelvis, because due to gravity, whatever fluid which is going to collect inside the abdomen is going to definitely go inside the pelvis, and from there definitely via this drain it is going to come out, right? So definitely abdominal drain is nothing. It is just placed after abdominal surgeries. You just have to remember the picture. Okay, this is the image based question. Okay. Now if I talk about the next thing in the general surgery, and that is wounds. Important topic, also helps you in other many of the subjects as well, like forensic medicine. Okay. If I talk about wounds, bache, definitely if I classify the wounds, okay, depending on its cleanliness, then definitely I can classify the wounds into two categories. One are called as the tidy wounds, okay, and second are called as the untidy wounds. So what do I mean by these terms? Definitely, so first if I talk about the tidy wounds, and second are your untidy wounds. Okay, what do I mean by these terms? First of all, tidy wounds matlab it is nothing else but the clean wounds. Okay, tidy wounds are nothing but these are usually the clean wounds, definitely. Okay, so please remember the tidy wounds which are there, it is applied for most of them. Okay, not for the Jackson Pratt, because Jackson Pratt is a smaller one. Okay. Important is tidy wounds which are there, bacho. These tidy wounds are nothing but clean wounds. These are clean wounds. That means there is no debris over here, no kachra over here. Okay, nothing like that. Okay, so these are special clean wounds, definitely, like sharp cuts. Agar sharp cut hote na koi, that is an example of a clean wound or a tidy wound. No issues with this, anybody? On the other hand, what are untidy wounds? Untidy wounds are usually the roadside injury wounds. Untidy wounds are usually the roadside injury wounds. That means there will be dead or dirty tissues present. There will be dead or dirty tissues present over here. Dead or dirty tissues will be present, or there will be a lot of debris also present. Dead, dirty tissues, debris which will be present. Example of this will be the roadside injury wounds. Okay. So patient met with a road traffic accident, and after that definitely the wound that he is having, which is having a lot of mud, a lot of small stones inside it, all of that, definitely that will be considered as an untidy wound. So if there is a sharp cut, that is a clean wound, that is a tidy wound. And if there is a roadside injury which contains dead or dirty tissues in it, it is an untidy wound. Why do we classify it like this? Reason is, bacho, this tidy wound which is there, it heals by primary intention. Okay, it heals by primary intention. What do I mean by this term? That means this wound will heal without even leaving a scar behind. This wound is going to heal without even leaving behind a scar. Yes, scar is not usually formed in a tidy wound. Okay, so important is that you have to remember, do we need any thorough cleaning or aggressive cleaning for this wound? No, definitely. Just normal cleaning is enough. Okay, just normal cleaning is definitely enough for this kind of a tidy wound. Okay, so definitely tidy wound जो होता है बच्चे, उसके लिए treatment क्या होगा? Just the normal cleaning is required. Okay, not aggressive cleaning. Just normal cleaning will be required and primary suturing will be done. Okay, just normal cleaning and primary suturing will be done. With the help of it, definitely these tidy wounds are going to heal. But if I talk about the untidy wounds, what is required for the untidy wound? Definitely untidy wounds are going to require aggressive cleaning. Untidy wounds are going to require aggressive cleaning. We have to clean them a lot. And what is used for cleaning for these type of wounds? Definitely for these type of wounds, definitely we have to use a lot of things. That means we have to use the normal saline also. We have to use normal saline as well, NS. Plus we have to use H2O2. What is H2O2? Hydrogen peroxide. Plus we have to use povidone iodine. What is povidone iodine? I hope all of you are quite aware. Betadine. ठीक है, जो brown color का होता है ना, betadine भाई. So definitely normal saline, H2O2 and povidone iodine should be used for aggressive and thorough cleaning of the untidy wounds. Right? That has to be remembered. Apart from that, you have to remember. Sorry. Then we have to also do debridement of these wounds. What is debridement? If there is any dead, necrotic, dirty tissues, that has to be removed. Removal of dead, this was a question, okay, a few years back though, but yeah, this was just a question. Removal of dead, dirty tissues from a wound is known as. So removal of dead, dirty tissues from a wound is known as debridement. Definitely all the debris and all the dead necrotic tissues has to be removed. That is what is known as debridement. So debridement is definitely required for a case of a untidy wound. Important is, please remember, okay, important is the golden period of a wound. The golden period of a wound is considered to be 6 hours. Golden period of a wound is considered to be 6 hours. That means if the patient presents with the untidy wound within 6 hours, if the patient presents with the wound within 6 hours, definitely, then we can just do a aggressive cleaning. Okay, most of the times we can just go for an aggressive cleaning, if required somewhat debridement, and then we can go for a primary suturing itself. Yes, we can close the wound itself, right? But if the patient usually comes after 6 hours, then a thorough aggressive cleaning is required along with a thorough debridement is required, and we cannot immediately close the wound. Okay, we cannot immediately close the wound. Tab tak tumhe bas bandage marna hai. You have to keep on cleaning it. Okay, and then once definitely you feel that a healthy granulation tissue is formed, then you may go for a closure as well. ठीक है, तो याद रखना है, अगर if the patient presents to you with an untidy wound within 6 hours of wound, definitely it is considered as the golden period. यहाँ पे the healing might occur with primary intention. So only cleaning and debridement and closure. But after 6 hours, definitely cleaning, debridement and not a immediate closure. ठीक है. Now let's talk about the various types of wound, बच्चे. The first type of wound which is there, as you can see over here, the first type of wound is what is called as an abrasion. This type of a wound, which is a very superficial wound. Can you see there is only damage or there is only injury to the superficial parts of the epidermis? Yes. Okay, there are 3 layers of the skin, right? The epidermis, dermis and the subcutaneous tissue. Here only the uppermost layer, that is known as your epidermis, has been injured. Okay? So what is abrasion? Abrasion is nothing but a superficial injury to the epidermis. Abrasion is nothing but a superficial injury to the epidermis. That's it. Okay? That is what is known as an abrasion. Important is, what is the most common type of an abrasion usually? What is the most common type of an abrasion? I hope you might have met with a road traffic accident a lot of times, or you might have seen someone meet with a road traffic accident, and then definitely due to the friction, they are getting these kind of abrasions, these linear scratch marks. Okay, so that is what is called as a gravel rash, or it is called as a brush burn, or we can even call it as the friction burn. That is usually seen in a patient of road traffic accident. Most commonly it is seen in road traffic accident, and that type of abrasion which is there, okay, these are called as the gravel rash or the brush burn or friction burn. These are known as gravel rash. इसको ही तुम brush burn या friction burn बोल सकते हो. Okay, brush burn or a friction burn. No issues with this, anybody? That is to be remembered. That has to be remembered. Important is, a lot of people think that ये wounds कहाँ से surgery में आ गया. बेटा wound surgery में ही आता है. Okay, for management, definitely the patient has to come to a surgeon itself. It is not the forensic medicine wala guy who is going to treat a live person. Okay, so definitely that is the reason wounds are to be studied in surgery itself. Okay, so forensic mein, that is definitely the type of wounds with the help of which you can determine something, but the type of wound and the management of the wound should be studied in surgery itself. Okay, so the first one is definitely abrasion, where there is superficial injury to the epidermis. The most common type is known as the gravel rash, brush burn, or the friction burn, which is seen usually during a road traffic accident. Next one which is there, this one which is there is known as a laceration. The next one is known as a laceration. Important is this laceration which is there. This laceration can be seen in a road traffic accident. Okay, what is seen in a laceration? Definitely laceration mein there is a deep wound. Yes, in laceration there is actually a deep wound which not only involves the epidermis but it also involves the dermis as well. Okay, so there is not only injury to the epidermis but there is also deeper injury to the dermis as well. So there is injury to the dermis and the epidermis, sometimes even the subcutaneous tissue, but mainly definitely it is injury to the epidermis and dermis for sure. Okay, that is important. Now, will it have a regular margin or irregular margin? It is going to have irregular margins. जो margins होते हैं, जो edges होते हैं इस wound के, definitely they are going to be irregular. And third important, as it is due to a road traffic accident or it is due to definitely a very crude kind of a wound. Okay, definitely here what will happen to the vessels and the hair follicles or the hair bulbs which are present in the base of the wound. So you have to remember, यहाँ पे जो vessels होंगी या जो hair follicles होंगे ना, they will be crushed. Yes, there will be crushing of the hair follicles. You have to remember definitely the vessels, the nerves, and the hair follicles. The vessels, the nerves, and the hair follicles definitely they will be crushed. They will be crushed at the base in a case of a laceration. Why I am telling you these points? Because bache, it is important to differentiate from a similar kind of a wound which is what is called as an incised wound. It is important to differentiate it from a similar kind of a wound which looks similar, that is known as an incised wound. Now, incised wound is also a deeper injury to the epidermis as well as the dermis, but it is not with the road traffic accident or it is not with a heavy weapon. Okay, it is usually with a sharp light weapon. It is usually with a very sharp and a light weapon, that is something like a blade, surgical blade, right? The surgical blade se agar tum cut maroge, that is a deep injury, but the funda is it is usually different from that of a laceration. And what are the differences from a laceration? So in this incised wound, you have to remember the patient is going to have irregular margins or regular margins. As it is a blade like weapon that you are using, definitely there will be regular margins. There are going to be regular margins or regular edges. Okay, first thing. Second important thing that you have to remember are the vessels, the nerves, and the hair follicles. Okay, the vessels, the nerves, and the hair follicles at the base will not be crushed, it will be cut. Okay, यहाँ पे क्या हो रहा था? The vessels, the nerves, and the hair follicles which were there, they were definitely crushed. But here the vessels, the nerves, and the hair follicles which will be there will be cut with the help of the blade. Okay, so that is the basic idea. A type of an incised wound is this one. Okay, a type of the incised wound is this one. What is seen in this incised wound? Can you see a younger male coming to you around 18-20 years of age? ठीक है, hospital में आता है definitely, and he is having multiple kind of multiple usually skin incisions the patient has given usually. और पूछा तो पता चलता है definitely he has either used a razor blade or normal blade definitely or maybe a surgical blade also, and he has given multiple cuts. ठीक है, तो अब वो definitely girlfriend को धमका रहा होता है कि भाई तू हाँ बोल दे, मतलब बंदी को धमका रहा होता है तू हाँ बोल दे नहीं तो मैं जान दे दूंगा. ओके, या फिर क्या हो जाता है उस चक्कर में, वो मजाक के चक्कर में एक कट क्या हो जाता है गलती से डीप लग जाता है, एंड देयरफॉर द पेशेंट स्टार्ट्स ब्लीडिंग प्रोफ्यूजली, फिर डर जाता है और फिर भाग के हॉस्पिटल चले जाते हैं. सो दीज आर व्हाट आर कॉल्ड एज, यस, द निब्बा निब्बी थिंग्स. ओके, सो इंपॉर्टेंट इज डेफिनेटली दीज आर व्हाट आर नोन एज द multiple superficial incised wounds बच्चे. These are known as the suicidal cuts, these are known as the hesitational cuts or the tentative cuts. ठीक है, so that is important. You have to remember these are known as the suicidal wounds. These are seen on the accessible parts of the body. These are multiple superficial incised wounds. Okay, they are also known as hesitational. They are also known as hesitational or the tentative cuts. They are also known as hesitational or the tentative cuts. No issues with this, anybody? These are multiple superficial linear cuts which are seen. Okay? So a lot of times this image has been asked in your examination, so please be aware of that. Okay? Next important is this one, bache. This is what is called as a avulsion or a degloving injury. This type of wound is what is known as an avulsion or a degloving injury. Now what is an avulsion or a degloving injury? When there is a flap which is formed. Yes. For example, there was some injury over here and now my skin has been separated from the underlying structures. मेरी skin अलग हो गई नीचे वाले हिस्सों से. So definitely there is a flap which is formed. If a flap is formed in a wound, that type of a wound which is there is what is called as the avulsion injury or a degloving injury. Okay, avulsion or a degloving injury. So that is important. You have to remember that this avulsion or this degloving injury is seen in run over injuries. What do I mean by run over injuries? That means somebody hit you with a car and definitely फिर वो हाथ के ऊपर से कार भी ले गया. Okay, the person has hit you with a car and definitely then that person has actually taken the car from your hand or from your body. Then definitely a flap of the skin or a avulsion or a degloving injury can be created as well. Okay, so run over injuries it is commonly seen. The another question which was asked. Okay, so flap is there. Flap is present as I've told you. Okay, so important is, as I've told you, that the skin is separated from the underlying structures. In previous year examination, definitely in previous year examination, the question was that the plane of separation is which one? Okay, there is separation between which layers of the skin, and that was a question. Okay, so please be aware of that. So please remember the plane of separation. The plane of separation which is there, it is between the plane of separation, you have to remember, it is between the subcutaneous tissue. It is between the subcutaneous tissue and the deep fascia. Okay, it is between the subcutaneous tissue and the deep fascia. So the upper flap which is created, it contains the epidermis, the dermis and the subcutaneous tissue, and it is separated from the whole deep fascia. Okay, so skin is completely separated from the underlying structures. That is what is the type of avulsion or a degloving injury. This has been a question. What is the plane of separation? Between which layers of skin is the plane of separation created? Okay. The next type of injury which is there, bacho, the next type of injury that you have to be aware of is this one. And what is this called as? This is nothing but a contusion or a bruise. This is nothing but a contusion or a bruise. So what is a contusion or a bruise? Contusion or bruise is nothing but collection of blood itself. Yes, due to some injury, if there is collection of blood, that is what is called as a contusion or a bruise. Okay, important is, it is due to rupture of small vessels. It is due to rupture of venules. If there is rupture of the small blood vessels like venules or capillaries, then there will be small collection of blood with irregular margins. Then that is what is called as a contusion or a bruise. Yes, a lot of your friends might be having it, okay, around the neck. Okay, so that is one of the type of contusion or a bruise itself. Okay, so please remember, this contusion or bruise is due to rupture of the venules definitely. Okay. And as I have told you, it is going to have the irregular margins. It will not be regular margins, and it is due to collection of blood. Okay, it is due to collection of blood. नहीं रे भाई, ये malignant melanoma थोड़ी है. This is just a contusion or a bruise due to rupture of the venules definitely. It is due to collection of blood over here with irregular margins. No issues with this, anybody? That's important. Next important, बच्चों, is this one. This is nothing but a nail injury. Okay, this is what is a nail injury. It is known as a puncture bite. This is what is a nail injury which is known as a puncture bite. And these puncture bites which are there, bacho, they are due to some nail injuries. The deep nail injuries which are there, na, these deep nail injuries are going to cause these type of puncture bites. These deep nail injuries are going to cause these type of puncture bites definitely in the sole of the foot definitely. Okay, important is, you have to remember कि these puncture bites which are there, they are due to nail injuries. Nail definitely are rusted. Nail is keel. Okay, कील की वजह से definitely अगर injury होती है तो definitely वो nail क्या हो सकता है, rusted हो सकता है. उसकी वजह से there is a very high risk of tetanus and other infections as well. That is the reason if a patient comes to you with a nail injury, it is very important to do a thorough and aggressive cleaning of this small wound also. Okay, so aggressive cleaning is required of this small wound even because it is a case of puncture bite. So aggressive cleaning is required. Okay, aggressive cleaning is required usually for this type of wound. Aggressive cleaning is required. No issues with this, anybody? That is important. Okay, so puncture bite or nail injuries where aggressive cleaning will be required. The next one, sarkari question of your exam, and this is what? This is nothing but your pressure sores. We can even call it as the bed sore. This is nothing but a pressure or a bed sores definitely. Now, where are these pressure or bed sores seen? These pressure or these bed sores, bache, they are usually seen in bedridden patients. Yes, these pressure sores or these bed sores are seen in bedridden patients. What do I mean by bedridden patients? Who are not getting up from bed. Okay, who are not able to get up from bed rather. For example, a person who has experienced paralysis, okay, or a person who is having paraplegia, hemiplegia, okay, and that patient or a patient who is having cervical spine fracture and who has been advised bed rest for a very long span of 3 to 6 months. Now these patients are definitely always lying on the bed straight. Okay? As they're always lying on the bed straight, definitely there is a constant pressure on their pressure points. And what are these pressure points? These your shoulder blades. ये जो shoulder blade है इस पे वजन पड़ रहा होता है ना, definitely constant pressure. There is constant pressure on these shoulder blades. Then there is constant pressure on the sacrum of the patient. Okay, all the weight which is there, it is on the sacrum. There is constant pressure on the sacrum of this patient. Or definitely, it is more commonly seen is also in patients who are constantly sitting. Okay, constantly sitting patients, एक ही जगह पे बैठे हुए, ठीक है? So definitely due to that also, patient हिल ही नहीं रहा जगह से. ठीक है, so definitely in that condition there will be more pressure on the ischium of the patient. There will be more pressure on the ischium क्योंकि you sit usually with the ischium at the base. Okay, you sit usually with the ischium at the base. Therefore, there will be more pressure on the ischium. So therefore, these can also develop at the ischium side as well. Okay, so these are definitely the various types of pressure source or the bed source. It is usually seen in bedridden patients due to excessive pressure at these pressure points. Okay, because the patient is not moving, the patient is not mobilizing properly. So therefore, definitely there is an ulcerative lesion which is created, ulcer-like lesion which is there. And in this ulcer-like lesion, can you see there's a lot of white tissue? So all that white tissue, okay, all that white tissue which is there are nothing but the debris which are there. Okay, that is called as the slough. Slough बोलते हैं हम उसको. ठीक है, all of these white tissue are nothing but गंदगी है ये सब. We have to remove this every day. Yes, you have to do regular dressing of these pressure source or bed source and you have to clean these every day. You should see a red granulation tissue. If you want to see a healthy wound, that means definitely you want to see a red granulation tissue. Okay, so that is the work of a first year resident usually in surgeries. Okay, हर रोज ड्रेसिंग करो and वो wound कैसा दिखना चाहिए, एकदम चमकदार लाल वाला wound दिखना चाहिए. That is what is suggestive of a that is what is suggestive of a healthy granulation tissue. Important is, please remember, these bedridden patients over pressure points, all right, or the pressure points. Important is, this is one of the reasons you might have seen in surgery wards कि the surgeon comes on the first day of the surgery or the second day of the surgery and he recommends कि please mobilize, उठ जाओ चलने लग जाओ. Okay, if you can definitely walk, definitely धीरे धीरे करके बैठो, धीरे धीरे करके चलो, but चलो. Okay, don't sleep all the time. ठीक है, so this is for one of the reasons is pressure source or the bed source also. If a patient is constantly sleeping in the same position, definitely he's at a higher risk to develop these pressure source. Okay, so usually pressure source or bed source are not commonly found in surgery wards. Okay, it is more commonly found in wards like medicine, orthopedics. Okay, orthopedics patients, because they are having these fractures and therefore they are in the same position. But at least the orthopedician should ask their patients to at least change their position. But no, they don't. Okay, so they're not concerned, and when definitely there will be ulcers or when definitely there will be sores, then there will be a surgery call which will be noted, and every day a surgery resident should go and do their dressings. So that is what is the funda. Okay, so that happens usually a lot. Okay, so that is important. Pressure or bed sores usually it is seen in bedridden patients over the pressure point. The most common site you have to remember, the most common site which is there, it is nothing but the ischium. The most common site is actually the ischium followed by the sacrum. The most common site is not the sacrum, the most common site which is there. Yes, they can also get it, because see why they will get it is because if it is a bedridden patient on a particular pressure point, there is a constant pressure. Will it receive enough amount of blood supply? No, it is not receiving enough amount of blood supply. Decreased blood supply is called as ischemia, and ischemia is further causing necrosis. Okay, and due to necrosis there is formation of an ulcer, and that ulcer is what is a pressure sore or a bed sore. Okay, that is important to be remembered. What is the treatment for this patient? You have to remember the treatment for this patient is definitely we have to clean these slough or these debris every day. That means debridement should be done and regular dressing should be done. So debridement and regular dressing is definitely required. Okay, so debridement and regular dressing is definitely required. No issues with this, anybody? That's the important thing. Okay, so these are the important things that you have to be aware of. Yes, debridement and cleaning definitely. So cleaning karoge, so you have to use the three things that I have already mentioned. Untidy wound, any kind of untidy wound, definitely you have to use these three things. Okay, and the last one which is there, bacho, this is what is called as a crush injury. This is what is a crush injury. Can you see that the skin and the underlying structures are completely crushed over here? Okay, so the skin and the underlying structures are completely crushed. So here you can see definitely there is crushing of skin. In a crush injury, there is crushing of skin and underlying structures. there is crushing of the skin and the underlying structures. This is what is called as a crush injury. Important is, okay, in a crush injury, there will be disruption of the blood supply, there will be damage to the nerves as well. Okay, so you have to repair the nerves, you have to repair the vessels as well properly. Okay, so yaad rakhna, that has to be remembered. That has to be remembered. No issues with this, anybody? Important is, can you see here, definitely there was a crush injury to his hand. Okay, it was properly debrided, cleaned properly. Okay, a flap was created and then definitely a flap was placed. Okay, so this is what is called as an art, and the surgeon is what is known as an artist. Okay, so that is what is required. No issues with this, anybody, bacho? That is more important. That is more important. No issues with this. Important is what? Now, a complication of this crush injury will be what? Complication of this crush injury is going to be what? Complication क्या हो सकता है कि अभी definitely there is crush injury, but the pressure between the fascia and the bone keeps on rising. Why? Because the muscle which is there, the muscle is having a lot of edema. The muscle is having a lot of edema, and due to that definitely, or there is a lot of hematoma, due to that definitely the pressure between the bone and between the fascia is constantly rising. There is increase in the there is increase in the pressure of the osteofacial compartment, and तो उसकी वजह से क्या हो जाता है? Due to this excessive pressure, the nerves and the vessels start get compressing. Okay, due to this excessive pressure, the nerves and the vessels start compressing, and as the nerves start compressing, the patient will have excessive pain. Okay, even on passive stretch, the patient will cry out in pain. बहुत pain होता है. Okay, and second important, definitely the patient is going to have decreased blood supply. Therefore, you will not able to feel pulse distally. Pulse ही नहीं feel होगी तुम्हें. Okay, so definitely, what is this condition called as? What is this complication of crush syndrome called as, anybody? What is this complication of a crush syndrome called as? This has been a previous year question. और तुम्हें पढ़ा होगा ना? What is this complication of a crush injury called as, anybody? When definitely the pressure in the osteofacial compartment rises, it compresses the blood vessels and the nerves. Very good. It is known as the compartment syndrome. What is the treatment? Important question. Repeated twice in exam. अब ये फेशिया और बोन के बीच में प्रेशर बढ़ रहा है, तो क्या करो? प्रेशर रिलीज करने के लिए फेशिया में मल्टीपल इंसिजन्स कर दो. यू हैव टू गिव मल्टीपल इंसिजन्स ओवर द fascia. You have to make multiple incisions over the fascia. That is called as fasciotomy. And when you make multiple incisions over the fascia, the pressure will be released easily. Very good. So complication is known as compartment syndrome. The complication will be called as compartment syndrome. And treatment of compartment syndrome, we also should be aware of. It is known as fasciotomy. The treatment of compartment syndrome is known as fasciotomy. You are going to make multiple incisions over the fascia. Okay, that is what is known as fasciotomy. कोई दिक्कत नहीं है यहाँ तक? Okay, now let's further talk about the outcome of a wound. Wound के बाद होगा क्या? Definitely. Okay, what will happen with the wound ultimately? So now definitely the wound is going to start healing. As the wound will start healing, बच्चों, definitely there will be granulation tissue will be formed. Okay, as the wound will start healing, definitely जैसे wound healing start होगी, there will be granulation tissue which will be formed. Okay, and then finally in this granulation tissue, this granulation tissue contains a lot of fibroblasts and collagen. This granulation tissue contains a lot of fibroblasts and collagen. More and more fibroblasts and collagen will keep on depositing in it, and then finally there will be formation of a scar. Okay, then there will be finally formation of a scar. Scar is usually formed after a lot of wounds, but not always it is an adverse or a bad scar. Okay, this scar will be formed for some time and then it will go off. Okay, then it will go off. Okay, so please remember, scar is formed after a lot of wounds, but it is not always a bad or an adverse scar. Okay, so that is important to be remembered. Now, important points which have been asked prior. Please tell me, which is the first collagen to appear during wound healing or the first collagen to appear in a granulation tissue? What is your answer? The first collagen to appear. The first collagen to appear during wound healing. The first collagen to appear during wound healing or in a granulation tissue. The first collagen to appear during wound healing in a granulation tissue. What is your answer? Very good, all of you. Very good. The first collagen to appear during wound healing or granulation tissue. This has been a previous year question. It is collagen type 3. It is definitely collagen type 3. Okay? Then it is replaced by collagen type 1. Okay? But if they ask you which is the most abundant collagen, which is the most abundant collagen, which is the most abundant collagen in a scar, which is the most abundant collagen in a scar, then what should be your answer? Then what should be your answer, bache? Then what should be your answer? Very good. Then your answer should be collagen type 1. Then your answer should be collagen type 1. Both of these are previous year questions. Please be aware of this fact. When the wound is healing, definitely, जब wound repair हो रहा होता है, there is formation of a granulation tissue, and the first collagen to appear in this granulation tissue or during wound healing is collagen type 3. Then it has to be replaced by collagen type 1. And when ultimately the scar will be formed, then the most abundant collagen which will be present in the scar is going to be collagen type 1 itself. Okay? So that is important to be remembered. Now, what is a scar? Definitely, this scar is nothing but an outcome of a wound. ठीक है, फाइनली वुंड के साथ होगा क्या? इट इज नथिंग बट अ आउटकम ऑफ अ वुंड. Scar is nothing but a outcome of a wound. What is going to happen with the wound? Definitely. Okay. Now, this scar is usually formed due to wound healing or wound repair. This scar is usually formed due to wound healing or wound repair. And what it is composed of? क्या होता है scar में? Definitely, scar is composed of mature collagen and fibroblast. As I've told you, for wound healing or repair, there are two important things which are required. One is definitely the fibroblast, and second are definitely the mature collagen. So both of these deposit, and they are going to form the scar. But is every patient going to have a bad scar or an adverse scar? No. But in few patients, definitely there will be adverse scar. Adverse scar is nothing but a bad scar which does not look good, first thing, and second important, it does not go off easily. Even after recovery, it will stay over there. ठीक है, ऐसे scar को बोला जाता है bad scar. ठीक है, so this adverse scar or this bad scar which is there, definitely it is going to occur due to some important problems. One problem can be anemia in the patient. Yes, if a patient is having anemia, deficiency of hemoglobin, okay, definitely there will not be enough amount of oxygen at the healing site. There will be hypoxia at the healing site, and therefore definitely the healing will be impaired. Healing अच्छे से हो पाएगी क्या? नहीं हो पाएगी. Next is definitely a patient having uremia. What is uremia? For example, a patient is having kidney failure, and due to that kidney failure, he is not able to excrete out urea from his body. There is excess collection of urea in his body, and excess collection of urea in the blood is what is known as uremia. So this urea is also going to affect the wound healing of the patient. It is also going to actually impair the wound healing of the patient. Next is definitely jaundice. Not only jaundice, but rather any kind of liver diseases are going to inhibit it. Okay, any kind of liver diseases are going to affect the wound healing. Next important is malnutrition. Definitely, if there is malnutrition, not enough nutrition to the patient, okay, the outcome of the wound will not be better. There will be formation of a bad or an adverse scar itself. Okay, wound tension. अगर if somebody tied a suture, but इतना जोर से tight कर दिया उस suture को, okay, if they applied a suture so tight बच्चे, that definitely what has happened, the skin edges which are there ना, we should just approximate the skin edges. हमें skin edges को बस approximate करना होता है, overlap नहीं करना होता. So if we overlap the skin edges, what is going to happen? Will there be proper wound healing? No. There will be improper wound healing, and that can lead to formation of a bad scar or an adverse scar itself. Okay, or if there are inverted edges, इतना tight कर दिया कि the edges, they are not inverted, they are inverted. ठीक है, if there are inverted edges, again there will not be proper wound healing. ठीक है, so these are the important things. Zinc is going to help in wound healing. Yes, zinc and vitamin C are the important things. There was a recent question of wound healing on wound repair पे. Zinc and vitamin C are going to help in that. ठीक है. Next important बच्चों is definitely the two types of bad scars. The two type of bad scars which are there. One is called as the hypertrophic scar, and second one you have to remember, it is known as the keloid scar. Now, both of these are examples of a bad scar or an adverse scar. What is the basic difference? Let's see that. The common thing between both of them is, both of them are due to overgrowth of dense collagen and mature fibroblast. See, what did I tell you? Scar is composed of collagen and fibroblast. But if there is over deposition of collagen and fibroblast, then what is going to happen? अगर ज़्यादा जमा हो जाता है collagen and fibroblast, then definitely a bad or an adverse scar is going to form. That bad or an adverse scar can be either a hypertrophic scar or it can be a keloid scar. Alright, that's important. Now important is this over deposition of mature collagen and the dense fibroblast, which is the collagen and the fibroblast which is there, bachcho. Definitely, if it is confined within the wound limits, bachcho, then it is going to be a hypertrophic scar. Can you see here the collagen and fibroblasts are deposited in extra amount, but they are limited within the wound limits. Wound limit के बाहर जा रहे हैं क्या? नहीं जा रहे. Therefore, this is what is an example of a hypertrophic scar. that we usually get on a day-to-day basis, right? Whereas the next one which is there, here there is excess deposition of collagen and fibroblast, but this time it is actually growing beyond the wound limit. Wound limit के बाहर जा रहा है, फालतू की extra growth हो रही है उसकी, and in which manner? In a claw-like manner, पंजे जैसे shape में हो रहा है वो, ठीक है? So you have to remember here it extends beyond the wound limits. Okay, it extends beyond the wound limits in a claw-like manner. No issues with this. This is what is called as a keloid scar. Can you see over here? It is growing beyond the wound limits and that too in a claw-like manner. Important is, अपने आप कौन सा ठीक हो जाएगा? So we know that spontaneous resolution is usually seen with hypertrophic scar. वो अपने आप ठीक हो जाता है. Even if you do not do anything for a hypertrophic scar, then also it is going to resolve on its own. अपने आप ठीक होगा. But no such spontaneous resolution is seen for a keloid scar. Keloid scars are to be treated. जब तक तुम keloid scar को treat नहीं करोगे तब तक वो नहीं जाएगा. Okay? So keloid scars are always to be treated. वो अपने आप नहीं जाते. Next important is definitely which one has a familial predisposition. What do I mean by that? Which one runs in the families? Okay? अगर माँ में था तो बच्चे में भी keloid scar की history हो सकती है, risk हो सकती है. So it is usually seen with a keloid scar. You have to remember. Usually your keloid scars are familial in nature. What do I mean by familial in nature? That means if mother or father, whoever in the family had a history of keloid scar, the child also can get a keloid scar after a wound injury. Okay? So that after an injury. Okay? No issues with this anybody, they are familial. Second important, they are commonly seen in the black race. That is nothing but your Afro-Caribbean race. Keloid scar is more common in the black or the Afro-Caribbean race. Okay? Whereas these two things which are not seen in the hypertrophic scar. Hypertrophic scar, okay, please remember, it is not familial. Okay, it can occur in anybody. It is not only in the familial origin. And second important thing is definitely, it is not common in a particular race. Matlab it can occur in blacks also, it can occur in whites also. So it is not common for a particular race. That you have to remember. Next important is the age group. And this is important. If I talk about the age group, bache, hypertrophic scar is more common in children. I'm not saying that hypertrophic scars cannot occur in adults, but hypertrophic scars are more commonly seen in children. तो अगर बच्चे में कोई wound होता है, okay, so definitely that can lead to a hypertrophic scar. But usually keloid scars are more common between the young adults. That is usually 10 to 30 years of age group. Okay, it is more common in young adults between 10 to 30 years of age group, and that too commonly seen in females. Most common site for both of them. Most common site of both of them is the sternum. Not only the sternum, whichever site actually has a bone beneath it, okay, whichever site has bone beneath it, ठीक है, ये देखो basic reason, ये क्यों होता है? If there is muscle beneath it, it will have good blood supply, yes. There will be proper nutrition, yes. So will there be formation of a bad scar or an adverse scar? No. But if that wound is above a bone, definitely, will it receive enough amount of blood supply? No. Okay, that is the reason it will lead to formation of a bad scar. And that is the reason, okay, any bony prominences, if they have an injury, there is a high risk of formation of these bad or a adverse scar, like a keloid or a hypertrophic scar. For both of them, the most common site is going to be the sternum itself. Treatment for a hypertrophic scar is what? Just massage. Yes. Okay, just massage with the moisturizing cream. The normal moisturizing cream which is there now. Okay, that is the definitive treatment for your hypertrophic scar. Even if you do not do this massage with moisturizing cream, the hypertrophic scar is going to go on its own. अपने आप ठीक हो जाने वाला है वो, ठीक है? But as the patient comes to you with a complaint कि डॉक्टर साहब ये नहीं जा रहा, definitely for that you can just recommend massage with a moisturizing cream and it is going to go on its own. ठीक है? That is important thing. Now, if I talk about a keloid scar, please remember keloid scar के लिए बच्चों, the treatment of choice if they ask you, okay, if they ask you the common treatment that we do usually, it is the intrakeloidal injection of triamcinolone. It is the intrakeloidal injection of triamcinolone. What is triamcinolone? It is nothing but a steroid. Okay, so triamcinolone is nothing but a steroid. So wherever the patient is actually having the keloid scar, you have to take this triamcinolone injection and you have to just inject this triamcinolone inside his keloid itself. Yes, intrakeloidal or intralesional injection of triamcinolone is given. Kab? Every 3 weeks. Okay, at 3 weeks intervals, definitely. At 3 week intervals, you have to give this injection of a triamcinolone in the patient's keloid. Until what time? Until it gets resolved. Usually it gets resolved in a span of 4 to 5 injections. Sometimes it needs 6 injections maximum. Okay, I'm saying. So maximum 6 injection की जरूरत पड़ सकती है, but usually the keloid goes off within like usually 3 to 6 injections. That depends on person to person, right? Important is, but if they ask you about best treatment, this I am talking about the most common treatment, which is also the treatment of choice, we can say. But if they ask you better than this, because even after giving a triamcinolone injection inside the keloid, there is high chance of recurrence. There is a very high chance of recurrence. So what is the best treatment then? So best treatment is not this. Best treatment will be, you have to remember, best treatment is actually surgical excision. Best treatment is actually surgical excision followed by interstitial cobalt radiotherapy. Okay, followed by interstitial, CO is nothing but cobalt, followed by interstitial cobalt radiotherapy. What do I mean by this now? We have to surgically resect or we have to surgically excise this one. Okay, so usually there is an ampule which is there. Okay, it is a 0.5 ml ampule. You have to load whole of that and you have to inject it in the keloid. Okay, one ampule which is there, you have to use it once only. You cannot use it on repetitive basis. So best treatment की अगर मैं बात करूँ बच्चों, so please remember this best treatment which is there. It is usually surgical excision. We have to remove or surgically excise the whole keloid scar and followed by that to prevent any recurrence कि वापस से वो keloid ना बन जाए. To prevent that recurrence in the base of that keloid scar. Once we have removed that keloid scar in the base, definitely you have to inject some cobalt. Okay, interstitial cobalt should be injected so that it emits radiations and that is going to prevent recurrence. उसकी वजह से वापस से keloid नहीं बनेगा. ठीक है, because it is going to inhibit the collagen and the fibrinolysis. Rather, it is going to inhibit the repair of the healing mechanism itself. ठीक है, so that is important. The best treatment is surgical excision followed by interstitial cobalt radiotherapy. No issues with this, anybody? That is important to be remembered. This intrakeloidal injection wala question has been asked multiple number of times. Okay, but apart from that, please remember, if they ask you the best treatment, it is not the intrakeloidal injection of triamcinolone. It is definitely surgical excision followed by interstitial cobalt radiotherapy. Okay. Now, if I talk about the types of wounds, bachcho, according to surgeries, yes, these I am talking about surgical wounds. These actually I am talking about the surgical wounds. Now, these surgical wounds, bachcho, they are classified into 4 classes. These surgical wounds are actually classified into 4 classes. Okay. So now, first of all, if I talk about the first of all is the class 1 wound. Class 1 wound is considered as a clean wound. Yes, class 1 wound will be considered as a clean wound. In class 1 wound, there is no evidence of infection. कोई infection नहीं है. Okay, absolutely it is normal surgery. It is a routine surgery, something like a hernioplasty, for example. Okay. Sorry. So class 1 wound which is there, it is a clean surgery or it is a clean wound. There is no evidence of infection. There is no evidence of infection. It is a clean surgery, something like a hernioplasty. Okay, something like a hernioplasty, definitely it is a clean surgery. Not a strangulated hernia, not a obstructed hernia, okay, not complicated hernia, the simple type of hernia that we are operating. Okay, so definitely the normal hernioplasty which is there, it is a clean surgery, no evidence of infection. So do we require any antibiotics? No, no antibiotics are required, because if there is no risk of infection, no antibiotics should be given for a class 1 or a clean variety of wound. Class 2 wound which is there, bache, class 2 wound is known as a clean contaminated wound. Class 2 wound which is there, it is known as a clean contaminated wound. In clean contaminated wound, there is a minimal risk of infection. In a clean contaminated wound or a class 2 wound, there is a minimal risk of infection. These are which surgeries? These are usually your elective gastrointestinal or genitourinary surgery. GI is nothing but gastrointestinal, GU is nothing but genitourinary. Okay? These are nothing but the elective. Elective ka matlab planned. And if you have planned a patient, for example, something like an appendicectomy, you have planned the patient for an appendicectomy. Definitely you have kept the patient nil per oral. Yes. And if you have kept the patient nil per oral, his intestines or his bowels are empty. Yes. So while you are operating the patient, will there be any leakage of any food material or any such things in the peritoneum? No. Okay. There is very, very minimal risk of infection. Yes. That is the reason why it is considered as a class 2 or a clean contaminated wound. Your elective or your planned GI or GU surgeries, something like appendicectomy. So therefore, treatment is what? Only antibiotics. And which antibiotics? Only therapeutic antibiotics. What do I mean by therapeutic antibiotics? If there is any leakage during surgery, or if you feel there is a risk of infection during surgery, then only after surgery you can give antibiotics. That's it. Only after surgery you can give antibiotics. There is no requirement of antibiotics before the surgery. Prophylactic antibiotics are not required. Okay? Next important is you have to remember class 3 surgical wounds are known as contaminated wound. Class 3 surgical wounds are known as contaminated wounds, and these contaminated wounds, bachcho, will have a रिस्क ऑफ सिग्निफिकेंट इन्फेक्शन, यहाँ पे इन्फेक्शन की रिस्क होती है जो बहुत ज्यादा होती है. ओके, देयर इज अ रिस्क ऑफ significant infection over here. These are which surgeries? These are emergency gastrointestinal or genitourinary surgery. That means we are performing appendectomy only in the patient, but this is an emergency appendectomy that we are performing in the patient. We have not planned this appendectomy, and that is the reason why the patient is not ready for the surgery. The patient has not been kept nil per oral. Patient ने खाना खाया हुआ है, and now if you are operating, now if you are definitely operating, what is going to happen? There will be leakage of these substances in the peritoneal cavity during surgery, and if there is leakage of these substances in the peritoneal cavity during surgery, there will be a very high risk of infection, or there will be a very high risk of peritonitis. That is the reason, to prevent that, it's better, if you are planning an emergency surgery, it's better to give prophylactic antibiotics as well as therapeutic antibiotics. मतलब सर्जरी से पहले ही एंटीबायोटिक्स दे दो, and also give antibiotics after surgery also for treatment. Okay, prophylactic as well as therapeutic antibiotics. Yes, acute pancreatitis can be an example of significant infection. Yeah, class 3 or a contaminated one. Class 4, which is there, बच्चों, definitely class 4 is a dirty wound. Class 4 is a completely dirty wound. That means there is a risk of gross infection. Gross infection, बहुत ज़्यादा infection है in class 4 or a dirty wound. Okay, so here definitely the patient comes to you with an abscess. अब abscess से और गंदा क्या हो सकता है? Definitely abscess is nothing but a pus collection. So abscess definitely is an example of a dirty wound itself. Or a case of perforation peritonitis. A case of perforation peritonitis, definitely that can also be an example. Okay, the patient did not have leakage during surgery, but rather the patient has come to the emergency with perforation of his peptic ulcer, for example, and due to the perforation of his intestine, that is the reason the patient has developed peritonitis. Now the infection has spread to the whole peritoneum, and there is a very gross infection, right? So that is the important thing. So gross infections के examples will be your abscess or your perforation peritonitis. No issues with this, anybody? Treatment की अगर मैं बात करूँ, definitely it will be prophylactic as well as therapeutic antibiotics. Same. In class 3 and class 4, both in these conditions, we have to give antibiotics prior to the surgery as well as after the surgery also. ठीक है? So इतना याद रखना है. Next, talking about the ulcerative lesions or the ulcerative wounds. These are very important, बच्चे, because common questions are asked from these topic, and a lot of people don't even study this. कि ulcers ऐसा कुछ होता है क्या? And these are very important. Okay, so please remember, let's talk about the ulcerative lesions. Okay, if I talk about the different kind of ulcers now, ठीक है, first of all, what is the most important thing to diagnose an ulcer? The most important thing to diagnose an ulcer is nothing else but its margins or its edges. उसके margin या उसके edge कैसे है वो देखना सबसे ज्यादा जरूरी है, because that is going to give you a hint about the type of ulcer. Important is, it is not only important in the clinical practice, rather it is more important in your MCQs. Reason is because they usually mention about the type of the margins which are present in the ulcer. But क्या होता है, अब ulcers पढ़े ही नहीं थे, तो definitely ये margins important होता है, ये पता ही नहीं चला. So they have given a classical hint in the type of margins, but we didn't read that, and that was the problem. ठीक है, so that should not happen. So what is the ulcer, बच्चे? Ulcer is nothing but a break in the continuity of a skin. बस break or breach in the continuity of a skin is what is ulcer. That is the definition. कोई नहीं पूछने वाला. So more important is you should have an idea कि break or breach in the continuity of a skin, okay, and loss of skin or loss of epidermis or dermis is what is known as an ulcer. Important is there are various kinds of edges or margins of an ulcer. The first margin, can you see there are sloping margins to an ulcer? These sloping margins are usually seen in which kind of ulcer? Sloping margins, बच्चे, are seen in two types of ulcer. One is a healing ulcer, second is a venous ulcer. Second, ठीक है, one is a healing ulcer. When the ulcer is healing usually, or if it is a venous ulcer or a varicose ulcer, then definitely it is going to have a sloping margins or sloping edges. The next one which is there that you have to remember, it is the punched out margins. It is the punched out margins. ऐसा लग रहा है ना, punching machine से किसी ने punch कर दिया है. So definitely this ulcer is actually having a straight or a punched out margins. So punched out margins जो होते हैं बच्चे, they are usually seen in three types of ulcer. They are usually seen in three types of ulcer. The first one that you have to remember is the syphilitic ulcer. The first one that you have to remember is the syphilitic ulcer. I hope all of you are quite aware that syphilitic ulcers are painless genital ulcers which will develop. Okay, so those are having this punched out margins. Second is a trophic ulcer. I'll talk about the trophic ulcer. Trophic ulcer is a painless ulcer again, which is usually seen in a patient of diabetes mellitus. So the diabetic ulcer होता है, diabetic foot होता है. That is nothing but an example of a punched out ulcer itself. And the third one that you have to remember is an arterial ulcer. The third one is an arterial ulcer. Yes, an arterial ulcer will also have punched out margins itself. An arterial ulcer is also going to have a punched out margin itself. Okay? Next important is the undermined edges. Can you see the margins or the edges of this ulcer are turned inwards? If the margin or the edges of the ulcer are turned inwards, bache, this is what is called as the ulcer with an undermined edge, and this is a very common question of your exam. Okay, ulcer with an undermined or inward turn edge, ये बहुत common question exam का. There are three important conditions which will have an ulcerative lesion with inward edges or with undermined edges. First is definitely the TB ulcer. Yes, the tubercular ulcer which is there. Usually it will be present in this area of the neck. Lymph nodes पे होता है ना. So definitely the tubercular ulcer which is there, it will also be an example of a ulcer with undermined edge. ठीक है, तो प्रीवियस ईयर क्लासिकल क्वेश्चन था, अ स्मॉल बॉय डेफिनेटली हैविंग सर्वाइकल लिम्फ नोड एनलार्जमेंट एंड नाउ ही इज प्रेजेंटिंग टू द OPD with the complaint of ulcerative lesion which is having undermined edges. यहाँ पे undermined edges with low grade fever in the child is a classical case of tubercular ulcer itself. ठीक है. Next important, you have to remember these undermined edges are also seen in a derma हो चुका है, तो please let me know a painful genital ulcer and painful lymphadenopathy. What is the diagnosis? Painful genital ulcer, painful lymphadenopathy. In that condition also you are going to see these undermined edges in the ulcer itself. Please let me know. Very good. Chancroid. Yes. So please remember, in a chancroid also you are going to have this ulcer with undermined edges itself, which is caused by Haemophilus ducreyi. Okay? So definitely in tubercular ulcer, in chancroid, and the third we are going to talk about is pyoderma gangrenosum. The third we are going to talk about is pyoderma gangrenosum. I'll write over here. Okay, these are the three conditions definitely which are going to have a inward turned or undermined edges of an ulcer. Okay? And the last two ones that you have to remember, the first one which is there, it is known as the ulcer with rolled out edges. The first one, as you can see over here, it is having ulcers, but this time with rolled out edges or rolled out margins. So these rolled out edges or these rolled out margins, they are very characteristic because they are only seen in one type of an ulcerative lesion, and that is the most common type of skin cancer of face, only face. That is what is BCC, known as basal cell carcinoma. So we know that basal cell carcinoma, though it is a cancer, it presents to us with an ulcerative lesion, and this ulcerative lesion is going to have outward turned edges. That is nothing but the rolled out edges definitely. Okay? They are going to have rolled out edges definitely. And last, can you see again there are outward turned edges, but they are raised. They are not flatter. They are raised edges. Okay, they are raised edges. We can say there are everted edges, or sometimes they even call it as cauliflower-like edges. They even call it as cauliflower-like edges. Okay? They are usually seen in two conditions. One is definitely squamous cell carcinoma, and second is usually a margolin ulcer. Recent exam question, 30th July. Okay, margolin ulcer definitely. So squamous cell carcinoma and margolin ulcer are going to have raised edges, everted edges, and cauliflower-like edges. No issues with this, anybody? That is what is important. This margolin ulcer, otherwise I would say this margolin ulcer is rather a risk factor for squamous cell carcinoma of skin. Okay, it is otherwise a risk factor for squamous cell carcinoma of skin. No issues with this, anybody? That is important. Now if I talk about this, the first kind of ulcer, can you see there are multiple ulcers which are very, very superficial, and they are having this white color part, dirty part, that is known as the slough. Okay? So this is usually seen on the medial aspect of the leg. This is above the medial malleolus over here. This is called as the gaiter's area of leg, and this ulcer at the gaiter's area of leg is usually seen due to varicose veins. So the patient was actually having varicose veins earlier, due to which there was stasis of blood flow at this site, due to which definitely there was necrosis or there was formation of an ulcer at the particular site. Got it? So this is what is an example of a venous ulcer or a varicose ulcer. This is a classical venous, or we can even call it as the varicose ulcer. This is a venous or a varicose ulcer. What is the characteristic of a venous or a varicose ulcer, bacho? You have to remember the venous or varicose ulcer, these are multiple, superficial, ulcer with which kind of margins or which kind of edges? With sloping edges. With which kind of edges? With sloping edges. So multiple superficial ulcers with sloping edges are a classical feature of the venous ulcer. Okay? That is important. What is the most common site for a venous ulcer? So you have to remember the most common site The most common site for this venous ulcer has been asked in a previous year question. It is the area just above the medial malleolus. ये जो area होता है just above the medial malleolus, it is the most common site for a venous ulcer. That is called as the Gator's area of leg. That is known as the Gator's area of leg. So this Gator's area of leg, बच्चों, is the most common site for a venous ulcer, just above the medial malleolus. Okay, Gator's area of the leg above medial malleolus is the most common site for a venous ulcer. Okay, important is here in this ulcer, definitely the patient's treatment will be done by what? The treatment of the patient, bachche, as I've told you, cause to I've already told you, right? Just write down the cause once again. Cause is nothing but the varicose veins. Or what is the cause for varicose veins? It is nothing but venous hypertension. The cause for varicose veins is nothing but venous hypertension. Blood jama kyun hota rehta hai? Because there is venous hypertension over there. Therefore, the veins are not able to drain properly, and therefore the blood keeps on collecting over there. Increased risk of infection that leads to formation of an ulcer. Okay, so that is the funda. The most common cause is venous hypertension. And treatment is done by which regime? So you have to remember, the treatment of a varicose ulcer or a venous ulcer is done by a Bisgard regime. Yes, the treatment of a varicose or a venous ulcer is done by a Bisgard regime. Now ये क्या बला होती है? Bisgard. Okay, it is a Bisgard regime. What is this bala Bisgard regime? In Bisgard regime you have to remember 3 E's. Okay, 3 E याद रखने. What are these E? First E is definitely educate the patient. Why do you want to educate the patient? To take the care of the wound. Okay, the patient should take care of the wound properly. Okay, he should maintain proper wound hygiene. अच्छे से clean करता रहे उसको, अच्छे से dressing करवाता रहे. So first is definitely the patient has to educate you have to educate the patient. Second important, definitely elevation of the limb. As there is venous hypertension, more blood flow towards the legs. You have to decrease the blood flow towards the leg. So you will ask the patient to take a cushion or take a pillow while he is sleeping. सोते वक्त definitely पैर के नीचे क्या लगा लो? तकिया लगा लो. ठीक है? So definitely elevate the limb. And third important is wear elastic compression stockings. Not exactly over the ulcer. पहले ulcer को अच्छे से dressing करनी होती है, and then definitely the patient can wear elastic compression stockings, because elastic compression stockings will prevent varicose veins in this patient, and if varicose veins are not there, venous ulcers are not going to develop. ठीक है? That is important. Next important is बच्चे this one. What is this? This is an arterial ulcer now. This is an arterial ulcer. You have to remember, arterial ulcer कैसा different है? It is usually at the similar site on the leg itself. But important is, here you can see there is a single and a deep ulcer which is there. अब veins का कैसा था? Multiple थे और superficial थे. But arterial ulcer is a single and a deep ulcer. And what is the cause for it? The cause for an arterial ulcer is definitely blockage. So if there is blockage in the artery, definitely the blood supply to this site will be decreased. And as there is decreased blood supply, what is that called as? Ischemia. And as there is a decreased blood supply, there is ischemia, which leads to necrosis and ulcer formation, right? So that is an arterial ulcer. Please let me know that arterial ulcers will be painful or painless ulcers. ये बता देना एक बार, painful होंगे या painless होंगे. So arterial ulcers, as I've told you, it is a single deep ulcer. It is a single deep ulcer with which kind of edges or which kind of margins? With punched out edges. It is a single deep ulcer with punched out edges. ठीक है, single deep ulcer with punched out edges. So the most common cause, as I've told you, it is nothing but the blockage itself. The most common cause is nothing but blockage of an artery itself. How it will be painless, बच्चे? How it is going to be painless? अगर तुम blood supply काट दोगे उसका, as you are going to decrease the blood supply to the nerves of this patient, as you are going to decrease the blood supply over here, will there be decreased blood supply to the nerves? Yes. And if there is decreased blood supply to the nerves are going to get irritated, and therefore the patient will have extreme pain. So these are extremely painful ulcers. Okay, so this is what is a characteristic differentiating feature. These are extremely painful ulcers. Okay, क्योंकि blockage की वजह से हो रहा है ना, blood supply is decreased, so these are going to be painful ulcers. Please remember that. ठीक है, so that has to be remembered. Next important is you have to remember, याद रखना, what will be the treatment of this ulcer. So the treatment of this ulcer is going to be revascularization and dressing. Yes. For example, what do I mean by revascularization? You have to restore the blood supply. तुम्हें वापस से blood supply ठीक करना है. That means, for example, if a patient is having atherosclerosis, you have to treat that. If a patient is having Buerger's disease, due to that there is arterial ulcer, you have to treat the underlying condition. Okay? So that is what I mean by revascularization. Okay? So definitely revascularization should be done and dressing should be done. Proper dressing and revascularization is going to help to heal this ulcer known as the arterial ulcer. The third type of an ulcer which is there now, the third type of an ulcer which is going to be there, it is called as the trophic ulcer. The third type of an ulcer which is there, bache, it is known as the trophic ulcer. As I've talked about the trophic ulcer, important thing is you have to remember that trophic ulcers are usually seen in which patient? Trophic ulcers are usually seen in patients of diabetes mellitus or leprosy. Yes, trophic ulcers are usually seen in patients of diabetes mellitus or leprosy. Both are examples of trophic ulcer. Can you see one trophic ulcer is seen in the sole of the foot? For example, a patient of diabetes mellitus who has developed a diabetic neuropathy. Now diabetic neuropathy hai, so definitely he is not having any sensation in his foot. So even if he develops a wound, he is not able to know, पता ही नहीं चलता उसको कि मेरे पैर में कोई जख्म हुई है, ठीक है? So definitely the patient is not able to know that he is having some kind of wound in his leg, and therefore the infection keeps on increasing over there, the wound keeps on increasing, and then there is a formation of a large ulcer, and that ulcer never heals. Why it does not heal? Reason is definitely, bachcho, first of all, the patient did not take care of the ulcer initially because there was no pain in the ulcer, because patient was having diabetic neuropathy, so there was no pain, no sensations were there. Second important thing, definitely, as in a diabetes mellitus patient, there is hyperglycemia, that is increased blood glucose levels. There will be more glucose at the level of tissues also. Yes, so jahan pe wound hota hai, where there is injury there is more glucose at that level also. So therefore there is high risk of bacterial infection. Due to that more glucose, bacteria are attracted, and therefore there is more infection at that particular site. And as there is again and again infection at that particular site, therefore it is not going to heal. Okay, and rather it will keep on increasing in size, and it can increase to a diabetic foot, and then therefore we have to go for even an amputation at times. Okay, so that is how a diabetic foot develops. This is nothing but a pressure sore itself. So you have to remember, yes, a pressure sore which is there, it is also an example of a trophic ulcer. Yes, pressure sore is an example of a trophic ulcer. The third most common site is usually the heel, as you can see in the picture. Okay, AD pe hota hai. Important is, as I've told you, that trophic ulcers which are there, definitely they are going to be painless ulcers. Why it is important for us to remember? Because बच्चों, this is going to help us to differentiate a trophic ulcer from an arterial. तुम बोलोगे सर क्यों, ऐसा क्या दोनों में common है? It is this edges. Punched out edges are not only seen in an arterial ulcer, punched out edges are also seen in a trophic ulcer. That's the reason. Punched out edge wala ulcer which is painful, arterial. Punched out edge wala ulcer which is painless, trophic. That is how simple it is. Got it? So that is important. You have to remember, trophic ulcer, these are nothing but ulcers, rather I will say non-healing ulcers. These are non-healing ulcers. With which kind of edges? Definitely with punched out edges. These are non-healing ulcers with punched out edges, and definitely, okay, they are going to have pain or not, no pain. They are not going to have any kind of pain. They are painless ulcers. They are going to be painless ulcers. Got it? They are going to be painless ulcers. No issues with this, anybody? That is important. Treatment is what? Treatment is debridement and dressing. Yes. Treatment is nothing but debridement and dressing. Even we can go for a vac dressing. What is a vac dressing? Negative pressure vacuum dressing which is there. Negative pressure vacuum dressing which is there. It is definitely going to, okay. No, it is not always black. Sometimes definitely it can be bright red in color also. It is not always black. Sometimes if there is debris over there, it can be white also. It can appear white due to the slough. More important is the history that they give usually. Okay? So definitely debridement and dressing will be there. Which is used as a treatment for the trophic ulcer. Okay? So that is important. Next, the last one ulcer that you have to be aware of, bachcho, is known as this ulcer. This is a classical important ulcer that you have to be aware of. This is what is called as your Marjolin's ulcer. If I talk about a Marjolin's ulcer now, this was a recent 30th July question and has appeared earlier also in the exam. Marjolin's ulcer ki agar main baat karu, this Marjolin's ulcer definitely, it is a very classical variety of ulcer. Why? Because it will usually occur in a patient of burns. Yes, for example, जहाँ पे burn हुआ था उसी साइड पे अल्सर बन जाता है. Okay, at the site of the burn scar, this ulcer is going to form. That is what is a Marjolin's ulcer. Important. Second important, this is a pre-malignant ulcer. What do I mean by pre-malignant? This ulcer which is there, it can turn into a malignancy or a cancer. Which cancer? As I've told you right now, definitely it can turn into a squamous cell carcinoma. Therefore, like other ulcers, here we cannot leave it just with dressing. So what should be done? Here the investigation of the choice has to be done. Investigation of choice is nothing but incisional biopsy. What do I mean by that? We have to take some amount of that ulcer, we have to take some samples from that ulcer, and we have to send it to the histopathology histopathological examination to rule out squamous cell carcinoma. अगर squamous cell carcinoma होगा, definitely the line of management will be different. Okay, and definitely the treatment is nothing but wide local excision, and if it is a large ulcer, then we might require a flap also. Okay, so let's write down. Definitely this marginal ulcer, बच्चे, you have to remember, it is usually seen on a burn scar. It was seen in a burn scar, and this was the classical history given in the recent exam also. So burn scar पे अगर होता है ulcer, definitely this is what is called as a marginal ulcer. Burn scar पे होता है. Okay, second important, definitely it is usually a painless, but sometimes it can be a painful ulcer. Usually it is painless, but sometimes it can be a painful ulcer as well, that you have to remember. Third important feature, as I've told you, here it is a pre-malignant ulcer. What do I mean by pre-malignant? That means there is a high risk of malignancy in future. There is a high risk of malignancy in future. Okay. Investigation of choice, if I talk about, it is nothing but incisional biopsy. Investigation of choice is nothing but an incisional biopsy. Okay. And lastly, if I talk about the treatment, bachcho, okay, incisional biopsy is done to rule out squamous cell carcinoma. Okay, so please remember, treatment is nothing but wide local excision. Okay, treatment is nothing but wide local excision with flap if required. Wide local excision with flap if required. Pre-malignant मतलब high risk of SCC होता है. Okay, high risk of squamous cell carcinoma. These are the important things about your ulcers which are seen at the level of the leg. ठीक है, which are seen at the level of the leg, बच्चों. ठीक है. Now important is, if I continue further, done with this, no issues till anybody? ठीक है. Yeah, I understand. Just complete the wounds na. Wounds is a topic definitely which you have to finish. Then definitely it will be all together na. So let's talk about the wounds and infections. So if I talk about paronychia now, what is paronychia, bache? You have to remember, paronychia is the most common infection of the hand. You might have studied this in ortho as well. So you have to remember, paronychia is nothing but the most common infection of the hand. Okay, paronychia is nothing but the most common infection of the hand. You have to remember, and it is what? It is actually the infection of the nail bed. It is actually the infection of the nail bed. Please finish it in continuity, otherwise you will not be able to understand things. एक टॉपिक जो है वो कंटिन्यू करना, मतलब इफ यू हैव स्टार्टेड द टॉपिक यू हैव टू एंड दैट टॉपिक. ओके, अदरवाइज बीच में कंटिन्यूटी लिंक टूट जाएगी तो क्या मतलब है, वंस तुम्हें वापस से डेफिनेटली यू विल नॉट बी एबल टू ग्रास्प इट टुमारो, राइट? सो दैट्स द रीजन. सो पैरोनिकिया व्हिच इज देयर बच्चों, इट इज द मोस्ट कॉमन इन्फेक्शन ऑफ हैंड. इट इज इन्फेक्शन एक्चुअली ऑफ द नेल बेड. ये जो एरिया होता है नेल के आसपास वाला, दिस इज व्हाट इज कॉल्ड एज अ नेल बेड बच्चों. सो इट इज इन्फेक्शन ऑफ द नेल बेड. As you can see, what is seen over here, there is nothing but the signs of inflammation will be there, and there will be pus over here. There is signs of inflammation and pus. Okay, what are the signs of inflammation? The patient is going to have pain, the patient will have redness, the patient will have swelling, and then definitely there will be collection of pus also at the site. What is the treatment for this? Definitely the treatment for this is going to be antibiotics, because it is an infection. As there is pus, there should be pus drainage also, which should be done with or without partial nail excision. Yes, in sometimes we might require a nail excision, but not always. Okay, हर केस में नहीं चाहिए होता, but yeah, in a lot of cases we also need to require we also need to do a partial nail excision as well. ठीक है. Next important is phellow. What is phellow बच्चों? This is what is a phellow. Infection of the pulse space of a finger. अगर यहाँ का infection हो जाता है, this is paronychia. But अगर यहाँ का infection हो जाता है, if there is infection of the soft tissue of the finger, if there is infection of the soft tissue of the finger, this pulp of the finger, this is what is known as a phellow. And phellow is a bacterial or a viral infection. Phellow is a bacterial infection, just like paronychia. But paronychia is infection of the nail bed, whereas on the other hand, phellow is actually an infection of the pulp space of the finger. So you have to remember that phellow which is there, phellow is actually a bacterial infection of pulp space in the distal phalanx. Okay, यहाँ distal phalanx के आसपास जो infection होता है pulp space का, that is what is known as the phellow definitely. Okay, as it is very close to the distal phalanx, can it cause infection of the distal phalanx also? Yes. Phalanx is what? Phalanx is nothing else but the bone. Definitely phalanx is nothing else but the bone. So definitely the infection might spread to the bone, so therefore the patient can have osteomyelitis of the distal phalanx, right? So the patient can have osteomyelitis of the distal phalanx. So if it is infection of the pulse space of a finger, that is what is phellow. Okay, here definitely as it involves the distal phalanx, the patient can have terminal phalanx or distal phalanx osteomyelitis, which is infection of a bone. Treatment will be antibiotics for this because it is an infection, or we can go for an incision and drainage if there is pus collected. Okay, infection, if it is there, then we can even go for this. Now last one is a herpetic whitlow. What is herpetic whitlow बच्चों? Herpetic whitlow is nothing but a viral infection of the pulse space of a finger. Yes, pulse space का infection होता है, but it is not bacterial now. It is a viral infection. So you have to remember that if there is infection of the pulse space of a finger, which is viral in nature, that is what is called as herpetic whitlow. In herpetic whitlow, definitely presence of pus will not be very common. Rather, there will be presence of painful vesicles. Yes, क्या बन जाएगा definitely? For example, what is the most common cause of herpetic whitlow? You have to remember the most common cause of herpetic whitlow is nothing but HSV1. That is herpes simplex virus type 1. Yeah. For example, a patient was actually having herpes genitalis and you were examining that patient. तुम examine कर रहे थे, but you examine that patient without gloves. तुमने बिना gloves के examine कर लिया. Now what is going to happen? Definitely, you came in contact with those vesicles of herpes. Okay, you came in contact with the vesicles of that herpes, and therefore now you have developed an infection of the pulse space of the finger due to the herpes simplex virus type 1, and that is what is known as a herpetic whitlow. Got it? So that is important. It is due to direct contact with these vesicles of the herpes virus. Okay, so that has to be remembered. That has to be remembered. No issues with this, anybody? Pus collection मैंने जैसे बोला कम होगा, pain and vesicles will be more. Treatment is nothing but acyclovir has to be given. If required, acyclovir can be given in a patient of herpetic whitlow. Got it? So that has been a previous year question. Okay, so these three are important. Next important is this one. What is this, bache? Can you see? First of all, if there is outpouching from an organ, okay, outpouching, there are three important terms that you have to be aware of. Outpouching from an organ is called as what? Outpouching from an organ is what is known as diverticulum. You have to remember, एक organ से अगर बाहर एक pouch बन रहा है, that is what is known as a diverticulum. So outpouching from an organ is known as a diverticulum. Okay. Next important is, if there is one-way communication with skin, if there is a one-way communication with skin, this is your skin, for example, and can you see there is a one-way communication with skin? If there is a one-way communication with skin, definitely, okay, and a blind tract is getting formed. A blind tract is getting formed, definitely. Blind tract is getting formed. Okay. This is what is called as a sinus. This is what is referred to as a sinus. Sinus क्या होता है? It is one-way communication with skin. It is nothing else but a blind tract. Okay, and that is what is known as a sinus. Okay. On the other hand, what is this? Can you see? This is actually not a blind tract, but this is not even a one-way communication. This is a two-way communication. This is a two-way communication which is there. It is two-way communication between two organs. It is two-way communication between two organs. One of the organs can be the skin, other organ can be anything. Even any organs के बीच में, अगर दो organs के बीच में एक abnormal communication है, if there is an abnormal communication between two organs, this is what is called as a fistula. This which is there is known as a fistula. Got it? So two-way communication between two organs is known as a fistula. Okay? That is important. So now important is these important things. If I talk about this, ये क्या है बच्चों? This is nothing but a case of the necrobiosis lipidoica diabeticorum. Okay, what is this ulcerative lesion called as? This ulcerative lesion is known as necrobiosis lipidoica diabeticorum. Yes, this ulcerative lesion is known as necrobiosis lipidoica diabeticorum. Now this necrobiosis lipidoica diabeticorum which is there, it is, नाम में ही पता चल रहा है, it is seen usually in a patient of diabetes mellitus. It is usually seen in a patient who is having actually a diabetic dermopathy. ठीक है, diabetic dermopathy जो इस patient में होती है, it is usually seen in those. So you have to remember this is a condition which is associated with a patient of diabetes mellitus. And which kind of lesion is seen? You can see definitely there is an ulcerative lesion. There is an ulcerative lesion with red color margins. There is an ulcerative lesion with erythematous margin भी बोल सकता हूँ मैं. ठीक है, तो erythematous definitely is nothing but red. So the examiner might use that word, but for simplification I am just writing ulcerative lesion with red color margins. That is what is definitely seen, and that is commonly seen on the shin of the patient. Shin क्या होता है अभी? Leg of the patient, for example. Okay, so that is what is seen over there. The next type of ulcerative lesion which is there, this is sarkari question of your exam, repeated multiple times of multiple number of times. मैंने क्या बोला? Ulcers and swellings are a favorite topic of your examiner. हर exam में minimum one question is usually seen. Okay, from both the topics or from either one of the topic. Okay, this is nothing else but a case of pyoderma gangrenosum. This is nothing but a case of pyoderma gangrenosum. Okay, no issues with this anybody? So important is यहाँ पे क्या हो जाता है बच्चे? Gangrenosum मतलब gangrene नहीं होता, necrosis हो जाता है, due to which there is formation of an ulcer. and here there is also formation of a lot of pus. Therefore, this condition is known as pyoderma gangrenosum. You have to remember this condition is associated with two important conditions. Yes, this condition is seen in a patient of chronic illness. And what are these chronic illnesses? It is associated with a patient of IBD. What is IBD? Inflammatory bowel disease. And which IBD? Crohn's disease or ulcerative colitis more commonly? Please let me know that in the chat box. And second, it is also associated with the patient of RA, that is rheumatoid arthritis. Okay, so this pyoderma gangrenosum bachcho, it is definitely commonly associated with the patient of inflammatory bowel disease and rheumatoid arthritis. Yahan pe the most common site is again the shin. The most common site is again the shin itself, that is the leg itself. Okay, very good. It is commonly associated with ulcerative colitis. It is commonly associated with ulcerative colitis. So please be sure that if they are giving you some history of ulcerative colitis in the patient, and then they are saying patient is having this kind of ulcer in the shin, and that too, which kind of edges are seen? Can you see the edges are turned inwards? The edges are turned inwards. That is undermined edges. Okay. So if they say the patient is having actually an ulcerative lesion with undermined edges, the patient is actually having an ulcerative lesion with undermined edges, and the patient is a known case of ulcerative colitis, definitely it has to be a case of pyoderma gangrenosum. It has to be a case of pyoderma gangrenosum. Very important topic for your exam. Okay, that is important. Okay. Next is what? This kind of a lesion which is there. क्या दिख रहा है इसमें? Definitely you can see a red color rash, and this red color rash is having paleness in the center. तो center में जो है वो clear है बिल्कुल. Okay, there is only red periphery which is seen. Red margins दिख रही है तुम्हें. And you have to remember that the site of this rash keeps on changing. आज यहाँ था तो कल दूसरी जगह होगा, परसों तीसरी जगह होगा. Definitely the site of this rash will keep on changing usually from time to time. Therefore, it is called as migratory. Red color is erythema. Okay, and there is necrosis also, due to which there can be formation of an ulcer. So this condition is known as necrolytic migratory erythema, and this is one of the top favorites of your examiners right now. अभी पहले pyoderma था ना, तो आजकल literally in 2 FMG exams and in 1 ETPG exam this same question has been repeated. One time image based, other time directly. ठीक है, तो necrolytic migratory erythema बच्चों. Okay, it is this condition, necrolytic migratory erythema. And you have to remember this necrolytic migratory erythema, it is nothing but actually a red rash or a erythematous rash we can say with central clearing. It is actually a red rash with central clearing, and it keeps on changing the position, therefore it is known as migratory. Okay, important is ये question तो एक बार diagnosis के लिए था. Second question was it is commonly associated with which among the following condition. So you have to remember it is commonly associated. It is commonly associated with what? A pancreatic tumor known as glucagonoma. It is commonly associated with a pancreatic tumor known as glucagonoma. Okay? So glucagonoma is nothing but a pancreatic tumor arising from the alpha cells of pancreas. Okay, so if a patient is suffering from that glucagonoma, it has been seen the patient is having higher risk of these necrolytic migratory erythema, where the patient is having a red color rash with central clearing. No issues with this, anybody? That has to be remembered. Now let's talk about few infections which are causing necrosis itself. Not only they are infection, but rather they are causing also necrosis. Let's talk about those few infections. Okay? This is a repeated question as I've told you. ये repeat question है, ये repeat question है exam का. ठीक है? Next important, if I talk about the necrotizing infection. Necrotizing infection मतलब the infections which can further lead to necrosis. Now, if there is a localized necrotizing infection, what is the patient going to have? Localized necrotizing infection में, here the patient will have features of what? The patient is going to have features of inflammation itself. The patient is going to have features of inflammation itself, and there will be necrosis in the local tissue. So therefore, what should be the treatment of this patient? The treatment of this patient is nothing else but antibiotics should be given for the eradication of infection. Antibiotics तो देना ही है, plus साथ साथ radical debridement has to be done. We have to go for a radical debridement. जितना भी necrotic part है, that we have to remove. We have to get rid of that necrotic part completely. Radical debridement has to be done. Next important is spreading necrotizing infection. Spreading मतलब it is not only present at the site of the infection, but it is spreading beyond that as well. हर जगह फैल रहा है. So if there is a spreading necrotizing infection, बच्चों, if there is a spreading necrotizing infection, you have to be aware that this spreading necrotizing infection can cause sepsis in the patient. What is sepsis? I'll talk about it. it is going to cause sepsis in the patient, and then the infection will spread throughout the body. Then therefore the infection can spread throughout the body, and therefore it can become life threatening for the patient. Yes, if there is a spreading necrotizing infection, the infection can spread throughout the body of the patient, and it can become life threatening for the patient due to the sepsis. So what is the treatment over here? Treatment over here in a patient of spreading necrotizing infection or in a patient of sepsis is first of all always a basic resuscitation. When a patient comes to the emergency, we have to go for a basic resuscitation. That means we have to manage the ABC, airway, breathing, circulation. Okay, we have to start IV fluids in the patient. We have to start IV antibiotics in the patient. Okay, so basic resuscitation or stabilization of the patient should be done. Basic resuscitation mein definitely IV fluids or IV antibiotics have to be started in the patient definitely. Okay, and definitely after this basic resuscitation is done, okay, in definitive management we are going to continue with IV antibiotics. Okay, we are going to continue with IV antibiotics in the patient, and along with that, depending on the type of infection, we are going to manage the patient. That means if it is a case of gangrene, we have to go for an amputation. But if it is a case of necrotizing fasciitis, we can only go for a debridement. Okay, so that is the funda. So what is this बच्चों? This is a type of spreading necrotizing infection itself. यहाँ पे क्या दिखता है? As you can see that not the whole layer of the muscle is involved, only the superficial layer is involved. So the superficial layer of a muscle is known as fascia. The covering of the muscle is known as fascia. So here the infection is not spread to the muscles completely, but rather it is only in the fascia of the muscle. Therefore this example, this case is known as necrotizing fasciitis. Okay, this is what is a case of necrotizing fasciitis. Image based question have been asked earlier. This is a case of necrotizing fasciitis. And if it is a case of necrotizing fasciitis, the patient is going to have signs of inflammation. The signs of inflammation, that means there will be redness, there will be pain, there will be edema or there will be swelling, and there will be definitely warmth at the local site. And the patient can even land up into sepsis further if it is not taken care of in time. Okay, वो तो मैंने बता दिया था. Now the types of necrotizing fasciitis you should have an idea about is definitely, one is the scrotum. Okay, the sites for necrotizing fasciitis I am talking about, one is definitely the scrotum. I show you the image for that, don't worry about that. One is definitely the scrotum, where the necrotizing fasciitis is known as which gangrene? It is known as the Fournier's gangrene, and this has been a previous year question you have to be aware of. Okay, so please remember, one site for necrotizing fasciitis can be the scrotum, and there it is known as the Fournier's gangrene. It is known as the Fournier's gangrene. Whereas this was a recent Fournier's gangrene ka bhi image has come very commonly in the examination. Okay? The next one is this bache. Here, can you see there is necrotizing fasciitis, but of the abdominal wall. Okay, it is necrotizing fasciitis of the abdominal wall. So if they say if there is necrotizing fasciitis of the abdominal wall, what is that called as? This was a recent NEET PG 2023 question, I feel. Yeah, it is nothing but Melanese gangrene. इस gangrene को क्या बोला जाता है? This is what is known as a Melanese gangrene. ठीक है? So please remember there can be two types of fasciitis. The necrotizing fasciitis in the scrotum is known as Fournier's gangrene, and the necrotizing fasciitis of the abdominal wall is known as the Melanese gangrene. So please remember this. This is very important to be remembered. Okay? Debridement will be done in this patient definitely. याद रखना, yes, only treatment is debridement. Only treatment is antibiotics and debridement. You will say, sir, do we not require orchidectomy? No, bache. No, we do not require orchidectomy. Testis removal is not required. Reason is, it is a superficial infection. It is only going to involve the fascia. That is the reason you can just remove the skin. You can just remove the fascia. Removal of testis is not required. Orchidectomy is not required in a case of Fournier's gangrene because the infection is not going to involve testis. याद रखना ये बात. This is very, very clear. It is not involving the testis. Not involving the testis. Okay? So that is the important thing. I'll show you the real image. It is a polymicrobial infection बच्चों. Polymicrobial. ठीक है? Polymicrobial का मतलब ये होता है there are multiple causes for it. Not only a single organism can be a cause for it. There are multiple causes for it. Polymicrobial infection it is. That yes, it can be due to anaerobes also. It can be due to pseudomonas also. Multiple organisms come together to form the image. Okay. So scrotum की image दिखा दो. Real life image. It is my patient, and that to one step further it is. Okay. And I'll show you to you. Just a minute. मुझे ये भी दिखाना है skin graft. Okay. Next important is definitely this one. As you can see, what is this? This is nothing else but a case of gas gangrene. This is also an example of a necrosis itself. But please remember, this is not an example of necrotizing fasciitis, but rather this is an example of a necrotizing infection. यहाँ पे the infection spreads to the muscles also. Yes, यहाँ पे the infection can spread to the muscle, यहाँ पे the infection can even spread to the bone as well. Okay, so this is a case of gas gangrene बच्चे, this is a case of gas gangrene. ठीक है, this is what is a case of gas gangrene, you have to remember. ठीक है, so if I talk about a case of gas gangrene, please remember definitely this gas gangrene में the most common cause which is responsible for gas gangrene, the most common cause which is responsible for gas gangrene, I hope all of you are quite aware, organism which causes infection and production of gas is nothing but Clostridium perfringens. Previously it was called as Clostridium velkai, पहले Clostridium velchai या velkai बोलते थे ना, now it is known as Clostridium perfringens. Why I'm calling it gas gangrene is, as you can see, definitely there's purplish or blackish color lesion all over the leg, so it is a case of gangrene. Definitely with that there is these air bubbles which are formed, these gas bubbles are only seen in a patient of hopefully now the voice is fine बच्चों, hopefully now the voice is fine, please let me know. Okay, great. So see, gas gangrene I was talking about बच्चों, gas gangrene is nothing but a condition which is due to an infection due to Clostridium perfringens, which is a bacteria. Previously this Clostridium perfringens was called as Clostridium velkai. It is not a superficial necrotizing infection like necrotizing fasciitis, but rather it is a deep necrotizing infection which is going to also involve the muscles. The patient is also going to have myonecrosis, that is necrosis of the muscles will also be there, and the infection can even involve the bone as well. Okay, that is the reason why you have to do a biopsy as well as a culture. Yes, you have to take a biopsy from this gangrenous part and you have to send it to the histopathology lab. Okay, and you have to also send it to the microbiology lab. Microbiology wale kya karenge? They are going to do a culture and they will tell you which organism is actually causing this infection. What is the treatment? Yaad rakhna, this condition is going to smell a lot, like that means there will be a lot of foul smell coming from this patient. Okay, a patient of gas gangrene smells foul. Yes, there's a lot of foul smell which comes from the patient due to the myonecrosis which is there now and due to the bone erosion. Therefore the patient is going to have a lot of foul smell coming. Treatment की अगर पूछेंगे, definitely now as the bones, as the muscles, everything has been destroyed, can we keep the leg over there? Otherwise what is going to happen? This infection is going to spread to the whole patient's body and the patient is going to land up into sepsis. Most of the patients of gas gangrene usually come to us with sepsis only. Okay, so therefore we cannot keep the leg over there, we have to remove the leg. That means we have to go for an amputation. Okay, so the treatment of choice which is there for a patient of gangrene or gas gangrene to be specific is nothing but amputation itself. It is nothing else but amputation. Got it? We have to remove the leg itself. Okay, so that is important to be remembered. Okay, so do you want to continue today or like we are actually left with infection ka hi part hai do, that is surgical site infection and sofa score वगैरह थोड़ा important चीज, and then surgical swellings will be there. Please let me know now. Okay, okay, ठीक है ठीक है, ज़्यादा सर्जरी पढ़ ली. I'll just show you the images once, that's it. Just a minute. हाँ हाँ भाई समझ गया. Just a minute, I'll just show you the images. Let me bring out the images somewhere, they will be there. ठीक है. Just a minute. Yeah, got it. Just a minute. Sharing the screen. See, over here, definitely. Can you see this is nothing but the skin graft wala picture? Are you able to see that? Yeah. This is nothing but the skin graft wala picture. Okay. Important is this is what is the skin graft. Can you see these ones at the margins? These are your staplers which are there. Okay. These are the usually slip staplers, the disposable staplers I told you now. So this is how the skin graft is usually fixed. Okay. We do the meshing, or meshing की वजह से the skin graft becomes more stretchable, and then this net like graft is placed with the help of these disposable stapler out there. ठीक है. So that is the skin graft. This is a case of ये तुम्हारा necrotizing fasciitis of the scrotum, that is nothing else but Fournier's gangrene. अब ये Fournier's gangrene कैसा था पहले जब आया था हमारे पास? Let me tell you. This is how the patient was looking. This was necrotizing fasciitis. This was a homeless person who came to our hospital, and he was not only having necrotizing fasciitis, but as you can see, there were a lot of maggots as well. भर भर के maggots थे, ठीक है? So definitely, along with necrotizing fasciitis or Fournier's gangrene, the person was also having a add-on gift, and that was maggots. Okay, so these maggots were present. See, okay, तो हमें maggots को भी निकालना था, and then definitely we operated the patient, and then when we operated, can you see? Definitely, have you removed the testes of the patient? No, now they are so clean. Okay, so definitely we have removed the only the upper part. We have actually just excised the skin and the fascia of the patient. Okay, but it looks clean now. Okay, so that is what is seen. No issues with this. This was a case of Fournier's gangrene now. No issues with this. बाकी definitely जैसे जैसे आते रहेंगे, I'll share the other images of my patients as well. Okay, चलो. Thank you so much. Good night and take care, बच्चों. Yeah, I'll send the notes immediately in the group. Hopefully you like the lecture, and let's see. Okay, let's make surgery more interesting. Sure. I'm sharing it. Don't worry about that. Thank you so much. Yeah, it will be at 11 a.m. itself. Same time will be starting. ठीक है?